Darlene, are you there?
Yeah, I'm online. Can you hear me okay?
Hello?
Yes, I'm online.
Frontline aides, are you
Yeah,
already there?
yeah, I'm online. Can you hear me?
Oh, there are colleagues from online.
Yes.
Welcome. We have failed to acknowledge you before. I'm Diana Meswele from the National AIDS and Health Promotion Agency. I'm directing the proceedings for today. I see you.
Great. Can you hear me as well?
Maybe you would want to introduce yourselves, those who are online, while we're waiting to
Sure.
colleagues to come back to the room.
Diana, can you hear me okay?
Can you hear me?
Yes, yes.
Are we muted? Maril, can you unmute that because I can't hear them?
I can hear you, Yolin. Hi.
I
Are
think
you
it's
able to
just,
hear me?
yeah, I think it's just in the
Okay.
room, Priyanka, yeah.
Yeah, it's a room issue. How are you?
Oh, we're fine. How are you?
Oh, good. Can you hear us now, Diana?
Yes, we
Great.
can.
Brilliant. Thank you very much for the introduction and for the moderation so far.
Hello?
Yes, can you hear us, Diana?
Yes, we can hear you. Can you please introduce yourself so that we include you in the meeting and our conversations?
Yeah,
Even when you're presenting.
Yeah, absolutely. My name is Ola McFadden and I work at Frontline AIDS, which is based in the UK and South Africa. And I work as an advisor on community health systems. And I'm going to be doing a short presentation on the HLM on PPPR. And I will pass over to Priyanka if you'd like to introduce yourself as well.
Okay, thank you very much, Yolin. I hope we are saying your name properly.
Pretty good.
Okay, I can't see who else is online now. The presentation is showing. So can you, the next person, introduce themselves, please?
Hi, can you hear me and see me?
Can you show the participants, please, for now? I'm just asking our tech guide to show the participants so that we can see you briefly.
My audio coming through? This is Priyanka.
Hold on.
Okay.
So, Mariri, I think if you stop sharing the screen, then Priyanka will appear on her video feed again as well.
We can see you now. Please go ahead.
All right. Great. Thank you for inviting me to this call. It's really great to be here. My name is Priyanka, and I am representing the 2023 TBHLM Affected Communities and Civil Society Coordination Hub. We are supported by the Stop TB Partnership and hosted by GFAN. The Coordination Hub was initiated for the purposes of supporting affected community members and civil society members to be able to meaningfully engage with all processes related to the upcoming TB-HLM. And we have been working with affected communities since January, and that is exactly what our focus has been. I hope to engage with all of you present in the room today, and perhaps the facilitators will allow me some time to present some updates on the TBHLM as a part of the session today as well. Thank you so much.
Thank you very much, Priyanka. I'm not so sure I caught your name properly. Forgive me if I'm mutilating it.
Sorry, I cannot hear you. Would you mind moving closer to the mic?
Okay, I was just saying I'm not so sure that I caught your name properly. It's Priyanka. Okay, thank you very much. And yes, we will look into giving you an opportunity to present. Okay, yes, you are definitely going to be presenting. So we're just wrapping up from the before tea session. There were two questions that or comments that I promised that I would take just to allow this to be a conversation more than just appreciating presentations, because I think some of us might not be used to this topic of discussion. So I think the more we allow people to interact, the more they'll begin to latch on and understand exactly what we're talking about. So please allow me to delay your presentation a little bit, Yolin, and allow two colleagues to ask their questions or to make the inputs. Mr. Dikang, I saw your hand up. Do you want to proceed?
Okay. Okay, thank you. My name is Moronga from USA. So, okay, mine is on workforce development. So I think one of the barriers to access equity and so forth is inadequate staff, but we continue to see our health workforce going to developed countries. So I don't know how the negotiations goes, but I think it's something that should be also be highlighted with developing countries, because developing countries invest, train these people. When they get competent, they eventually migrate for better packages and so forth. So my suggestion would be there should be some form of support then, kind of to replace the people that have been taken to those countries. So it's something that I just wanted to put forward. Thanks.
Okay. I'm not sure if everybody caught what you were saying. I was struggling myself. But I believe you were speaking to migration of competent healthcare workers from Africa to other parts of the world and how that is affecting universal access, and how we can position that as a global issue that we need to all contribute to addressing. Because if they're migrating to another country, which is able to pay them better, then it means we're weakening African systems, response systems, I get. All right. One last. Did you have something to say before the break?
Thank you. I was just going to add to what Dr. Masheko was saying.
Okay.
Maybe to introduce myself, I'm Dr. Ratidum Fakensele from Ministry of Health, Department of Public Health.
I didn't catch that.
Dr. Oratilum Fakensele.
Okay.
Yes, from Ministry of Health. What I was going to add is basically what Dr. Masheko was talking about when he speaks to health systems. So the discussions that are really critical right now is ensuring health systems that are resilient.
Mm-hmm.
Resilient in that even if anything is to come, we'll still be able to stand. And the resilience of health systems is anchored on UHC and therefore on PHC, right? And we do know that PHC is very much anchored on community services.
What is PHC again?
Primary healthcare.
Okay.
So discussions around ensuring that our health systems don't get derailed when we do get a pandemic, or even if it doesn't get to pandemic levels, maybe it's something that is just in Botswana only. It's something that we have to have really serious discussions about how we are ensuring that all the building blocks of the health system, all 6 or 7 of them, depending on which one you're looking at, which is service delivery, health workforce, as my brother from USA is talking about. How do we ensure that we not only train, but we retain these competent people we are training? And how do we ensure that we incentivize them properly to ensure that they can be retained? How do we ensure that we make their workspaces to be conducive for them to want to stay? And then we look at all the other building blocks of a health system to ensure that it's resilient. Because what usually happens is, especially in pandemic areas, we will be looking at maybe ensuring that there's money, but it's not money for sustainability. It's money to keep a stopgap kind of money. So going forward in these discussions, maybe something that needs to come out is ensuring that countries sustainably finance health. Therefore, come up with kind of finances that develop capacities to last, to be resilient, and two, to ensure that such kind of financing for health systems, especially for pandemics or for pandemics, they can be mobilized as quickly as possible. Dr. Masheke, when he was talking about communities, he spoke about event-based surveillance, which is part of early warning systems. Even if we are to have our CBOs working in the communities and we're able to detect this early, if we can't mobilize resources like this, then we are still not going to win. So discussions needs to be around ensuring that all these building blocks of the health system are agile enough to be able to react to anything really. Thank you.
Thank you very much. I think you're gonna kill me or I get killed by the next presenter. I see two more hands, so I'm having a bit of a conflict. What do you think? Should we allow two more speakers and then move on? Or should we allow the other presentations to go on? Okay, so Nana and who else? All right. I'm gonna have to Zara you, my sister. No, you need to be on the mic for people who are online. Settle in first, Nana. So
Yeah,
that you can
yeah,
be
thanks. Just to say, in terms of reflecting on what the ministry is doing in order to prepare for pandemics and also to look at the issue of UHC, I just wanted to contribute, and I may have missed it when colleagues were speaking, to say that there's quite a lot of different technical working groups at a national level looking at different aspects of what needs to be considered, especially around making sure that Botswana has a resilient, sustainable system for health. One of the particular areas which I'm very passionate about is around health financing. So Botswana's finalizing its health financing strategy towards universal health coverage. So some of the issues that partners and colleagues talked about in the space around ensuring we have, the right workforce, we have community engagement, we're looking at public primary healthcare as an approach, and really trying to look at all the things that we can do to ensure that as a country, we prepare against future pandemics and also integrate the intersectionality with universal health coverage. I think it's important that we recognize that there are efforts being made, but also what it's telling us is that, resourcing is a real issue. So we also need to look into how do we make sure that the resources that are currently being put to health are being used efficiently, right? We need to look at allocated efficiency. We need to look at how much resources are going to support the health force, and are we using it in the right way? Are we using it for the right things? And also, even as we say we're meaningfully engaging communities, are communities being adequately resourced? So, I just wanted to flag it as we're having these discussions in the next few days, that we have to make sure that as a country we're doing that, but also as a region, as a global response to health, that these are things that we're recognizing. Thank you.
Thank you very much. Can you at the tail end introduce yourself? And the next speaker, can you introduce yourself before you speak?
Nana Gleason, BONELA. Thank you.
Thank you, Nana. Last speaker, please introduce yourself.
Yes, my name is Len from Achap. So my point is, I think what's probably defeating us here in Botswana, or actually in the region, it's the amount of data we are generating. And for the last 20 years, there's HIV data that has been generated. And the data warehouse or through DHIS, community DHIS. And still, we have not actually interrogated our data to really form a baseline for whatever interventions we want to implement. So it will be it's worrying that we go for these high level meetings where declarations are made at a global level, and then how do we then come back and operationalize those declarations, and how do we even ask for resources in terms of financial resources when we don't have the data that will back up the request that we are making. Currently, there's the data warehouse. There's a lot of data sitting in the data warehouse. I don't know if we have capacity to interrogate what's in the data warehouse and what can be done with the data in the data warehouse as a country. As a starting point, there is an exercise of interoperability that has been going on. Health and death and births are interoperable. And we want to actually add more other entities into the exchange layer so that we utilize that. During COVID, we had access to mobile phones where you were receiving text messages on what interventions are coming out. How much have we utilized that space again to really spread the messages that we want to put across the communities? So I think the starting point really it's the data that we generate on a daily basis to start interrogating that, so that when we go out and ask or contribute in the global agenda, we have the strong data to use for that. One other area is the climate change. I think they will talk about climate change and all these to see where we are as a country in contributing to climate change and these new diseases that are coming up. Thank you.
Thank you very much. I didn't want to cut you, even though the intervention was a little bit long. Colleagues, these are very strategic things that are coming out, and I hope that we are noting them for later as we prepare the advocacy document. But what seems to be coming out very strongly is the issue around digitization and also strengthening our information management systems for learning or for learnings and sharing of knowledge and best practices. Because right now Africa is a mine, and it's a resource for practitioners, public health practitioners and experts across the world. They study what's happening here, and then they take the information and run with it as it is coming from outside. So I think if we, as you are saying, strengthened our data and information management systems, we might actually begin to put out information that can be looked at by the rest of the world. So that's an ask for the HLM to say, can we support low resource or low income countries or middle income countries to strengthen the information management systems for health response systems for the benefit of the rest of the world. Another issue again is the issue of health financing, to say it's not just a Botswana issue. And I think this goes to the Africa common position to say, we know that we are always on the verge of some kind of disaster or another. And I'm sure that it's not just Botswana that gets disorganized whenever there's a crisis that hits. And our primary health models obviously have been affected across the region. So again, that's one thing that we can propose to the Africa common position, that colleagues feel very strongly that we need to invest in health financing, but also strengthening health systems across the region. I have seen hands, but I want to beg that we go to the next presentation so that we are not so behind. Otherwise, we'll eat lunch at 2, and then we'll never really be able to catch up. So colleagues online, allow me to usher in Elon from Frontline AIDS to talk about community engagement and leveraging lessons learned from the HIV response to PPPR. Please introduce yourself and your organization. I think partners need to know what Frontline AIDS does and how Frontline AIDS has supported Botswana, especially the community responses. in terms of being able to meaningfully put communities at the center in the area of community system strengthening and human rights and gender and so on and so forth. Over to you, Elon.
Great, thank you very much, Diana. Can you hear me okay? Can I just get a confirmation if the participants in the room can hear me all right? Maybe,
yes, we can hear you.
Brilliant, thank you very much. So yes, thank you very much for the introduction. As Diana said, my name is Olin McFadden and I'm from Frontline AIDS, which is the largest global network of HIV, civil society organizations and community groups in the world. We work across a partnership in all different regions of the world. And in Botswana in particular, we work very closely with BONELA, as Diana has mentioned, on really supporting the community-led and community-based responses to the HIV crisis and building on those learnings and making sure that those learnings are incorporated and really strongly supported in the HIV response. And really since COVID-19, we've also been working very closely with BONELA and within our partnership on the issue of pandemic prevention, preparedness and response, which is PPPR. So I'm just going to give a short presentation now looking at the some of the key issues and discussion points around the high-level meeting on PPPR, which is scheduled for this September, really looking at some of the key learnings from the HIV response for this and really making sure that we build a roadmap to a PPPR, which is really community and people-centered. So Mariri, if we could go to the next slide, please. Great, thank you very much. So really, I think many of us saw that following the really devastating impacts of COVID-19, that there's been a growing consensus at the national level, internationally, that countries must be able to strengthen their capacity for PPPR, which is pandemic prevention, preparedness and response, so that we're all in a much better place to counter the next pandemic when it happens. And really, from our point of view, there are very many important learnings from the last 40 years of the HIV response, which need to be incorporated to really successfully build the strongest PPPR that we make. So for us, one of the key learnings from the HIV response from those last 4 decades is really the vital leadership brought by communities and how this is really critical for addressing pandemics effectively, in particular reaching people who'd otherwise be left behind and developing strong, really person-centered care models. And we also saw this during COVID-19, the way that much of the infrastructure in HIV was utilized and redirected in the COVID-19 response. What we have seen, unfortunately, is that in many of the high-level global discussions on PPPR, the crucial role of community-led responses and civil society is really been systematically neglected and underused and unrecognized in these discussions. So Mariri, if we could go to the next slide, please. So some of the other key learnings and experiences from both the HIV response and COVID-19 is that we saw across the world really hugely uneven access to vaccines and other medical technologies. As in really the first 20 years of the HIV pandemic, pharmaceutical companies prioritized their profits over human lives and access to medicine, denying life-saving products to people in low and middle income countries. So for future PPPR efforts to be a success, there needs to be an effort to build on the efforts of the HIV response to address these sort of existing inequalities and access to medical technology, and really prioritizing a rights-based, person-centered approach with strong commitments on equity and equitable access, technology co-creation and transfer, and creating larger systems for developing and producing medical supplies. So Mariri, if we can go to the next slide, please. So those are some of the key learnings that we really think need to be included in the high-level political declaration on pandemic prevention, preparedness and response. And this declaration has been developed over the last several months. And the conclusion of this will be the high-level meeting on the 20th of September in New York. Just to give you a little bit of a background, the real central goal of this high-level meeting process was to further mobilize political momentum and integrating multi-sectoral approaches towards strengthening pandemic prevention, preparedness, and response. And the overall discussion has been co-facilitated by the countries of Israel and Morocco. And in the last couple of months, some of the key events that have taken place is in May, there was multi-stakeholder hearings on the high-level political declaration in New York, which was attended by BONELA and other civil society representatives. Over this summer of June and July, the member states have been negotiating the final text of the political declaration. The original schedule was that on the 26th of July, the final text was meant to be completed and put under what they call silence procedure, where there would be no further negotiations. But there's actually been quite a lot of debate and argument on several key points of the text. So what's happened is they've been forced to create additional time for more negotiations on the text between countries. And at the moment, the new deadline is that for the 30th of August, there'll be a hopefully final PPPR political declaration text, and that will then be ready for the meeting on the 20th of September in New York, where the declaration will be endorsed by member states. Maria, if we can go to the next slide, please. Thank you. So we've seen several drafts of the political declaration as it's been developed over the last several months. And we've seen several key focus areas in the draft, which have also been building on what some of the key discussions were in the multi-stakeholder hearings in May. So we saw in May that at the multi-stakeholder hearings, there was a focus on lessons learned from the COVID-19 pandemic, and also the best way to financially invest in pandemic prevention, preparedness, and response. And in the latest draft of the political declaration, which has still been developed, there's a really strong focus, or attempted focus at least, that the draft has language on equity, on global governance of pandemic preparedness, on leadership and ensuring accountability for successfully implementing pandemic preparedness. There's also reference to overarching other health-related issues such as UHC and the HIV response and the response to TB and malaria, and also discussion on financing and investments, how best to finance these PPPR initiatives. So Maria, if we can go to the next slide, please. Thanks. So really, across like different regions, internationally, nationally, like there has been attempts to coordinate to get some key community asks around the high-level declaration on PPPR. An initial challenge was really coordinating and creating these civil society asks, as there was no coordination mechanism set up for civil society the way there was for TB and UHC. Really, for the first half of this year, a primary request was that this type of civil society coordination mechanism be created. But unfortunately, this was not taken up by the lead organizers for the PPPR HLM for various reasons. That they said it was too complicated or it was too late in the process for this to happen. So really, for the PPPR HLM, it's been quite difficult in comparison to TB and UHC to try and coordinate across civil society, as there isn't an official mechanism for this. But despite this additional challenge, civil society have attempted to coordinate themselves through different global and regional networks and work to create some agreed upon unified asks for what they want to see in the HLM political declaration. So Maria, if we go to the next slide, please. And some of the key asks which have been developed by civil society through these self-organized negotiations include that the declaration should have commitments in it recognizing the key role of community leadership and representation in decision-making processes and governance bodies for any new PPPR structure. And this should be from conceptualization and design on to implementation. And this should be at the global level, but also at the national level. The language in the declaration should commit to really achieving equity in PPPR and make sure that there are actions to achieve this. So this would include reforming intellectual property restrictions, which would strengthen the availability of vaccines and medical technologies, supporting access guarantees in publicly funded medical research, and also supporting and increasing regional manufacturing capacity through licensing and technology transfers. And also asked that the declaration would commit to building on the existing infrastructure and expertise in the responses to HIV, TB, and other diseases, as this is the strongest base from which to develop really effective future PPPR. And also that the declaration would commit to continued sustainable funding of the responses to HIV, TB, and other diseases. So Miri, if we can go to the next slide. So I've included links in these slides, which I think the meeting organizers will be able to share with you, just examples of two of these sort of consolidated civil society ask statements. One is a global level document, which was put together by the Coalition of Advocates for Global Health and Pandemic Preparedness. And the second document was a sort of joint civil society ask statement from civil society and communities in Asia and the Pacific, which was developed across all three HLMs in advance of the meetings in May and then September. So Mariri, if you can go to the next slide, please. And just to give an example, these are some of the different advocacy activities which have been taking place over the last few months around the HLM PPPR. So as I mentioned in the stakeholder hearings in May, civil society participated as delegates and also as speakers in these stakeholder hearings. BONELA were able to speak on one of the key panels to talk about the learnings from the HIV response and the role of civil society. GFAN and others have been convening webinars in June and at other dates over the summer to really try and bring together civil society to update them on what's happening across the three HLMs, and in particular for the PPPR HLM. Other organizations such as the Stop TB Coalition and APCASO have been holding joint working groups for CSOs in various regions, including in Asia in March. And there's ongoing work by other civil society coalitions, including the Coalition of Advocates for Global Health and Pandemic Preparedness and the Pandemic Action Network, who are also coordinating across various networks and regions. So if we go to the last slide, please, Murray. So really the next steps between now and the meeting in September, which is really when the declaration is going to be launched and officially signed. The general civil society registration to attend the meeting is open if your civil society organization has what's called ECOSOC status. This is like a special accreditation with the United Nations. So it's still open for civil society to participate in the meeting if you try and register for this before the end of this week on the 11th of August. Also, all countries and member states are being encouraged that for their national level delegations, which are going to New York for the HLMs, that these should include as much as possible civil society in their membership. So do direct outreach with your government missions in New York and with ministries of health and foreign affairs to join these delegations if you would be interested in attending. And civil society will be continuing to develop side events such as this and other asks between now and September over the coming weeks, just to really make sure civil society are as aware and up to date as what's happening with the PPPR political declaration as possible. And this will be fed through GFAN and other networks that you may or may not be operating in. So yeah, that was the last slide. So that was just sort of a general update on some of the key learnings from the HIV response for PPPR and the HLM, and then some of the key activities that have been taking place and will be taking place to make sure that civil society and the HIV response will be able to feed into the political declaration on PPPR. So I'm happy to take any questions on that, or if there's any follow-up information people would like, I'm more than happy to share that on with people as well. Thank you very much.
I'm still failing to say your name properly. Colleagues, that was a very useful presentation that speaks to not only community responses, but also how civil society is positioned to contribute to the high-level meetings and how we can transmit our priorities up to the very top of the chain. And again, the emphasis is on people-centered, equitable, gender transformative, and rights affirmative policy frameworks. And I think Elon's presentation was basically emphasizing on that, but also emphasizing positioning the learnings from our very own responses as Africa, and recognizing community leadership, and emphasizing that in the next set of commitments or global policy commitments, we need to position utilizing community knowledge and leadership to ensure that we don't only pay lip service to a people-centered, equitable, and gender transformative or rights affirmative approach, but we actually live in the reality. One other thing that he highlighted was issues around the global policies and legislative frameworks on intellectual property. And I thought that was very relevant to us from our experience with the COVID-19, but also with the HIV response. We remember that there was actually even a TRIPS flexibilities framework recognizing that the patent and intellectual property laws at the global level were very stringent and disadvantaged middle income or lower income countries from being able to access essential medicines and diagnostics for TB, for HIV. So this is a very important issue that we need not forget. Also looking at how we can position other regions of the world to be able to bring their technologies to the world. We know that our diagnostics are not so very bad sometimes, and often they are learnings that come from our very own soils, but they travel to the world and become touted as if they are from the West, not acknowledging the contribution of the global South in diagnostic technologies, and also being able to contribute to the manufacture or the making, in simple language, the making of medicines. I think we tend to rely so much on the global West because we are hidden, our gems are hidden. So these are some of the things that I think came out about African leadership or about the global South leadership from Elon's presentation. We were running a little bit behind schedule. If there are any two burning platforms, I would like to allow 2 people to go. Otherwise, we're going to move to the next presentation and then try to catch up as we are discussing, going back to the other presentations that happened before. So can I get an indication of, thank you very much for your excellent presentation. I forgot to say that. We're always blessed to have you support us as a country and as a region. Any reactions to Elon's presentation? Silence means consent in layman's terms. If you are quiet, it means you are saying no. So you are saying yes. Move forward. Okay, I was not going to allow the facilitators to speak, but if you are quiet, I will allow 2 interventions. Cindy?
It's a very small one, just to share our experience as we were, advocating for a rights-based PPPR document. And we could see that there is some level of pushback around the rights language. So I'm thinking, as civil society, this is something that we need to continuously push, that as long as we don't look at health as a rights issue, then we are going to continuously have problems. So it's important that in our document that we also recognize that it's important for the responses to be rights-based, and also given that we have seen a pushback on the rights language.
Okay, thank you very much, Cindy. Nana, that's the final one.
appreciate Elon's presentation. And also just to say that when you see the feedback in terms of the level of advocacy and engagement that's happening in the region, that's happening globally, we also need to recognize that as Botswana civil society and as activists who want to, change the status quo around what's happening with health, around what's happening from a social perspective in Botswana, we need to become much more engaged.
Exactly.
I think this is a great example of what's happening out there, and we need to learn from this experience to say, going forward, right? What do we need to do? How do we need to come together? How do we need to consistently speak with one voice? How do we need to make sure that the agenda is a common agenda? I think the doctor talked about One Health approach at an Africa level. I mean, some of these initiatives, the reason why they're strong and they're impactful is because people come together and have a conversation and agree a way forward. I'm very excited about tomorrow, about the advocacy part of this, but it also is giving us a learning experience to say, this is what other people are doing, and this is how we can learn from this and become this kind of mechanism going forward to really strengthen health responses in Botswana and in the region. Thank you.
Thank you very much for that excellent intervention. And I don't know how we can go move forward as a country, civil society and government. These are excellent conversations that we're having here, but I know that they don't happen every day. And I can assure you that more than 50% of people in this room are not aware of the efforts that are ongoing from our very own civil society partners contributing to the global policy, health policy, including resource mobilization. I know that a lot is happening within civil society, but we don't convene forums or knowledge sharing platforms where we can actually, feedback each other, problematize things, and establish common priorities. So it's a few people running around doing a lot of work, but not really being able to carry others along. So maybe it's our own moment of reflection. I also know that there's a lot of civil society platforms regionally, but the interface with governments, how strong is that? Because I'm sitting here worrying about beyond the civil society platforms of reaching to the HLM and contributing to the HLM documents. How well are we going to be able to interface with our own government beyond coming with an already prepared document? I wish that we could have a better approach of engaging in country before we even get to preparing that advocacy document. But it's just a moment of reflection. I think going forward, to use civil society partners, I think we need to conversate with government and alert them that we are missing an opportunity to have a joint dialogue that is not just civil society aside or a few government people represented, but to have a meaningful engagement that is multi-sectoral, that brings on board everybody's ideas and priorities. So with that, I'm going to allow one last intervention. Elon, I hope this one is talking to you because you have honored us and been sitting there waiting for questions.
Okay, thank you very much for your wonderful presentation. My name is Siva Kebadile. I'm the rapporteur for these 2 days. I just have one question, a question and also a reflection. In terms of the community structures that exist, at what level does civil society participate within those community levels? And how is the accountability when it comes to feeding to the national structures at Ministry of Health? In addition to that, Achap mentioned how much data we have. And we had a presentation earlier that spoke of the country context. But I'm afraid to say our country context did not really paint a clearer picture of our statistics, a clearer picture of where we are standing in addressing the pandemic, how much was invested in the COVID-19 response plan, and how much morbidity did we experience as a nation, and how are we going to be responding going forward. What I picked from the presentation was a response plan that seems to be put in place, but it's still not engaging all the structures that needs to be participating, especially in relation to civil society and community structures.
I believe this one is speaking to Dr. Macheke, but you can also contribute to it, Ilan. I think it was very clear, so without wasting time, let me let Dr. Macheke to respond, and his colleague from the Ministry of Health.
Yeah, thank you very much. First of all, I would like to thank the presentation that was very enlightening in terms of how civil societies and lessons learned from previous pandemics. The question of involvement of the civil society in our planning it's something that we will take note of, but honestly speaking, we always feel we have a multi-sectoral and multidisciplinary team, because the idea of IHR and its core capacity and capacity building in those areas is focused on ensuring that everyone is represented.
Mm-hmm.
So when we meet to go through even the country risk profile, it's not a Ministry of Health thing. We have people from the military, we have people from the local government, we have people from the NDMOs and things like that. And the assumption has always been that everyone is represented. Okay. Or if not represented, they have been invited.
Okay.
So we will look into it further to see, is it the issue of people not coming on board, but they were invited, or it's an issue of they were not invited in the first place. But we can't have any plans and response actions without everyone being on board. That one is key, and it's part of the tenet of what IHR is all about.
Okay.
And in terms of the cost and all those details, I think those are available and can be shared if need be. Yeah. Thank you.
Thank you very much, Dr. Macheke. I think it's also an issue of visibility, because this is a new institute that was established, I believe, after COVID-19. Excuse me? The institute, the Public Health Institute, is it established yet? It's still to come.
Yes and no. As an autonomous department, it has been established.
Okay.
But the vision is to have it as a state-owned enterprise.
Through an act of parliament or what?
Yes,
Okay.
yes. That's what we are targeting for the November parliamentary sitting.
Okay.
So that the bill, it can now officially be established as a parastatal then.
Okay.
Yes.
And did civil society have any contribution to the formulation and ideas about what structure should it take and how should it be governed?
So the idea here is that when you look at, we're talking about the legal and all this. So the presidential task force, in it, we had people from the Red Cross, from Business Botswana, sitting in the presidential task force. And it's one of those committees that recommended the establishment of the BPHI. So that's why I was saying, sometimes when we talk about representation, it's an assumption that when you have as a committee advising and recommending certain things is already representing everyone, but sometimes it's not necessarily the case. Yeah, thank you.
Anything to add, Elon?
Yes, thank you very much for the remarks from the Ministry of Health. I would just maybe quickly add, in his remarks, he mentioned the IHR, the International Health Regulations. So at the moment, also at the global level, the IHR are currently under review post-COVID with the aim of improving them and making them stronger in terms of being able to guide countries in the response to health emergencies and pandemics going forward. The process of that review is a lot more private and difficult to engage with at the global level, but we're hopeful that there'll be some language in the revised IHR that will include stronger language on the engagement of civil society and communities in pandemic responses and global health emergencies. So we'll see how that develops, but we'll hope for the best that there will be stronger language in that around civil society engagements.
Thank you very much, Elon. There's some kind of feedback on our side, so we're a little bit distracted. But thank you so much for sharing further insights on what's going on in the landscape of global policy. Do you know if there's anything happening in terms of filling the gaps that might be there or that we know are there in terms of the global position in of course, some people stand to benefit from that. And I've heard several people talk to the issue of putting profits above human life. So we know that there was the TRIPS flexibilities when the world realized that some countries were left behind in terms of accessing essential medicines and diagnostics. What is different this time in terms of positioning these issues at the HLM? Are we going to have foresight already at that level to say, can we look at intellectual property laws and patents laws and see how this has played out in preventing access for COVID-19 and for HIV? And we don't want to keep on having that going forward, where people are profiting from the loss of lives. What is it that we can position in terms of our framing of our advocacy as the Africa region, where a lot of the low-income countries are found, in terms of what goes into these documents, to talk to the issue of patents and holding rights to intellectual property rights, and the right to make medicines or to replicate medicines using non-brand names or patents. Thank you very much.
So at the moment, there's two big PPPR processes taking place globally. One is the HLM declaration, which has been coordinated at the UN in New York. And the second is what's been called the Pandemic Treaty, which has been coordinated at the UN in Geneva and by the WHO. Now, to be honest, for the HLM political declaration, which has been going to be hopefully finalized in September, from what we've seen, the language on equity, reform of intellectual property is probably going to be quite weak. There might be some reference to it, but it won't be very strong. Where potentially there might be much stronger language around reforming intellectual property and equity and access to medicine is in the pandemic treaty process in Geneva. And what we've actually seen is that process is now behind schedule because it's been such a contentious issue between broadly the global north and the global south. And actually the African delegations, the Africa bloc at the UN in Geneva have done a very good job of having a coordinated position, sort of fighting to try and get stronger language on equity and access to medical goods in that document. In particular, there's quite a big fight going on at the moment where countries in the global north are trying to, in the pandemic treaty, they're trying to get language in the document saying that for example, in Botswana, if there was a pandemic outbreak, the government or the ministries there would be obligated to share genomic data from that pandemic very, very quickly within a few weeks with international medical bodies so that then that information could be used to develop medical technologies and medical responses such as vaccines to pandemics. what a lot of the global south countries, the Africa bloc, Bangladesh, other countries have been saying is, if we include guarantees like that, that we in our countries are going to share medical data from pandemics in our countries, what we need is guarantees that any medical technology that is developed from that information, vaccines or diagnostics or therapeutics, any sort of help from medical technology, we need guarantees that we will have full access to that, and it won't be restricted based on intellectual property barriers, on expenses, on based on where the copyright is owned, based on where the manufacturing company is. So I think really the challenge, the opportunities and the challenges around intellectual property and equity to a certain extent will be raised in this HLM process. But I would say for civil society who are very keen and interested in those topics, that the real area to look at between now and May 2024, which is when the pandemic treaty process is going to be finalized, is that process, because it's really where there's quite a lot of argument and conflict between different member states and different regions on how or if IP and equity will be reformed.
Yeah, thank you very much, Ilona. I think these are very important discussions that partners are listening to here attentively, that we need to be very woke for equity not to be inequality or inequity again, because we agreed to certain things, including sharing our medical information and genomes and all that stuff, only for it to be used to develop medicines and diagnostics that will be sold to us again or hoarded by the global West. So thank you very much for that presentation. We need to be able to move to the next one. Unfortunately, we're running a little bit of behind time. So thank you very much for your presentation and your engagement. The next presentation is actually pre-recorded, and Priyanka will be the anchor. We'll be taking questions after we go through the presentation. So the presentation is on TB, addressing intersectionalities, and I want to usher that in right now. Priyanka, can you hear me?
Yes, I can hear you.
So we're having a challenge in loading the presentation so that we can see the speaker at the same time, be able to view the presentation. So if you don't mind, can I call, because we're running behind schedule, can I call the next presenter while they're still trying to address the challenge so that we make a little bit of saving on time? Do you mind waiting?
Sure, not an issue.
Okay, sorry about that. So the next presentation then would be the presentation on country perspectives on the 3 HLMs, a CSO perspective from Dumiso Gacha from Success Capital. The pronouns are them and they. Thank you very much.
BONELA. Good morning, colleagues. I hope you're all well. Fisam just shared that he's quite surprised that Botswana is cold. He expected that it would be hot. But I think that's quite a testament to climate change and some of the various elements that I will touch on in a bit within the context of, oh, sorry. My apologies. So I'm just going to share my screen quickly. And I hope those who are online can also see it. And I'll just try, in the interest of time, to browse through a lot of the different issues. Thank you for the previous speakers for illuminating quite a lot of elements. I hope those online can also see it. So I'm going to be illuminating on these issues basically based on quite a lot of other forums that include member state delegations or certain elements, networks, enablers that also sort of contribute towards high-level processes. And so that was just highlighting some of those that at least we have had some touch points on, whether it was side events, parallel reports, advocacy, or influencing. And so basically, I think what's important as a backdrop for the 3 HLMs is acknowledging that the highest, that the highest point in terms of reporting on SDGs is with the voluntary national reviews. Normally that happens during the high-level political forum where heads of government meet in New York and end up engaging in some of these issues. Botswana last presented on the voluntary national reviews last year when it held the office of the President of the General Assembly through the permanent mission representative. And then I think, yeah, so more importantly, acknowledging that CSO participation is possible as long as the state submits a country report. And then highlighting the fact that there are quite a lot of country and technical consultations. One of them includes the UHC, the state of UHC consultations that we had helped sort of conduct last year. And then also, I think a few things were mentioned in terms of some assessments or reviews that were done by the Ministry of Health, but more importantly, also with UN agencies. And then, of course, technical working groups. I think that was one of the comments that came, but then also that there are quite a lot of UN-specific expert panels that contribute, whether it's, working groups on tax and so forth. And so I think a lot of these are different sources that can often help in influencing civil society participation or positions towards member state delegations. And then, of course, permanent mission engagements. So essentially the representatives that are based in New York. So there will be an embassy for a country, but then also there's a permanent mission to the United Nations, especially where they have to consult with capital, whenever there is a voting or whenever there is a declaration and whenever there's some form of negotiation that's to take place. the linkages, I think really the role of civil society has been making sure that there are some of these links with United Nations in Geneva, which hosts the treaty bodies and special procedure mechanisms. So that includes, Universal Periodic Review, the Committee on the Elimination of Discrimination Against Women, and several others. And then obviously this allows, to be able to advance advocacy, but I think from a health perspective, we haven't had many opportunities country-wise to advance health through the SDGs, Agenda 2063 at the African Union level. And then we managed to do a bit in terms of the African peer review mechanisms, but also through CEDAW, the Committee on the Elimination of Discrimination Against Women, with the auspices of the gender machinery that's based across the country. And then also acknowledging strategic spaces, and I think I highlighted them in the previous slide. So I just wanted to give a little bit of a view or a scan of some of the commitments that Botswana has committed to from a health perspective, as a lot of these have informed some of the policy influencing mechanisms. And I think it's always a good reminder, last year when we're doing something around primary healthcare, it was helpful looking at some of the different metrics around the Abuja Declaration, because there are certain actual percentages that are identified on there that commit the state, and according, whether it's against GDP or according to the annual spending. And I think for us, or from that perspective, in being able to sort of trickle down some of that knowledge at a district level through different workshops was illuminating, because a lot of individuals sometimes aren't always aware of whatever's happening in New York or in Geneva. And so I think, with the 3 HLMs, Eolan actually mentioned the fact that, yes, there might be a gap with the pandemic prevention preparedness response, but UHC 2030, as Makelemi had already mentioned, has got quite a lot of different constituents that are widely represented. I think it's over 1,000. And then also with the Stop TB partnership that's hosted by the UN Office for Special Project Services. Is it? No, but it's... Oh, sorry, there's a internet delay, so maybe I'll speak a little bit slower. Oh, it's not even showing. I don't know the one of them. But I'll make sure to share the actual document on the chat since I'm logged on, just in the interest of time. And so just to further put it to context, acknowledging that only 1% of global health spending actually ends up in Africa. And so I think this is obviously really a call to say that we need significant change in the current health landscape. So from the UHC perspective, UHC 2030 had developed an action agenda that essentially came from all the different constituents, private sector, private foundations, civil society. And so they had various consultations, and this was building off of the success of the 2019 political declaration. And I think from that time, it was quite interesting during negotiations, as Makelemi had actually mentioned, it's quite surprising where you end up hearing the United States really sounding the same as Russia, as an example, because of differences around reproductive rights. And not wanting that kind of language to be reflected in a political declaration. And so it's really quite eye-opening. It's really quite eye-opening when you hear some of the commentary that will be coming from the floor in that instance, because it obviously does help and influence how you shape your advocacy. And then, just acknowledging that UHC, then obviously the movement for UHC has been trying to influence a lot of these other mechanisms that obviously do quite a lot in terms of commitments with regards to health financing, but also ensuring that there can be progress across the different SDGs, and obviously more prominently with universal health coverage. And so I think, within this context, and when we're looking from a global perspective, it's acknowledging that there's a lack in terms of essential health services. And I think there was a mention around, skilled workforce, which obviously has been emerging as part of one of the other constituents of the civil society engagement mechanism. And then acknowledging the pandemic in itself and the kind of impact that it had, and then the various challenges that impact health security globally, which I think Botswana is not saved from or excluded from. So the high level meetings are obviously a unique opportunity. And I think, you know, when you look at how the multi-stakeholder engagements came about, you know, if we had not caucused and we had not prepared ourselves, it would have been a missed opportunity because of the short timelines in terms of registration, eligibility, around just even accessing and registering for that space. But I think civil society was quite well represented. And if I understand correctly from the previous, while they were developing the second version of the UHC, the second version of the political declaration on UHC, they were actually sort of looking on whether there was the action agenda included on there, or one of the co-facilitators in one of the sessions. So that was just a positive in illuminating, you know, the power of multi-sectoral approaches. And so these are the 8 action areas: championing political leadership, so ensuring that there's commitment for UHC. The state of UHC reports have been showing that there's obviously a lack of progress, a lack of monitoring, and a lack of action from the 2019 declaration, leaving no one behind, obviously making sure that people on the move, sex workers, LGBTI, and other sort of groups that might be disenfranchised as a, you know, as a result of poverty, being, you know, based in remote locations, can be included, adopting enabling laws and regulations. I think acknowledging the importance of removing human rights barriers, then strengthening health and care workforce, as I had mentioned, for quality healthcare, investing more, investing better. I think there was a question that came around the state budget, and in our previous reviews, we had actually seen that some of the work, that there would have been more ideal if social participation would have been a factor in the context of health allocations, which I think is obviously a welcome development, given the fact that in the last, before the last budget speech, the Minister of Finance had actually conducted some consultations, which I think is uniquely placed because it also houses the SDG Coordination Office. And then, moving together towards universal health coverage. And I think what we have been able to advance, acknowledging that Botswana does not guarantee the right to health, is that UHC has obviously enabled to have some conversations that can help fulfill that. And then obviously guaranteeing gender equality, which is quite a common thread in so many health strategies, and then connecting universal health coverage with health security. And so a lot of some of these features is making sure that there's focus on action. So not just making the commitment, but also ensuring that there's a lot of country focus. As I think, you know, people have then realized that even if you try from a regional global perspective, at the end of the day, it is the capital that ultimately determines to what extent you can fulfill universal health coverage. And then obviously, you know, the context of leaving no one behind. And then, you know, when we're talking about the healthcare and workers, and I think what's important is during the same time of the 2019 political declaration, the Global Action Plan on SDG 3, where I think it was Angela Merkel and the president of Ghana at the time, who had written a letter to rally for the acceleration of SDG 3, or the fulfillment for SDG 3, noting that there were certain gaps that were falling behind, and this is pre-COVID. And so I think, what UHC 2030 has established as a common position is ensuring to advance a common language across all the 3 different HLMs, because obviously that makes it a little bit easier for being able to advance certain advocacy narratives, but also acknowledging that they're different stakeholders. The state delegation at the high-level political forum isn't always the same state delegation at the UN General Assembly. And so I think that there's obviously a huge need to make sure that language is common and that it can easily relate across the 3 different HLMs, and more importantly, also the SDG Summit, which will be happening just before the 3 different HLM meetings. Recognizing UHC as an umbrella for all the different health issues, because it does touch on quite a lot of different social determinants and really does advance intersectionality. And then you're advancing for the commitment to promoting and institutionalizing social participation. So how do we ensure that communities can be included across the 3 different HLMs? And then lastly, just strengthening the different links in acknowledging that UHC isn't a standalone element or component, in that, you know, there are obviously many other sort of facets and sustainable development goals that it does touch on and it does enable within the sustainable development framework. Some of the recommendations that came from the consultations was ensuring that there's a multi-sectoral and segmented coordination. So incorporating and, acknowledging that the infrastructure for social participation already exists in country, but how can we ensure that there's a bridge between the different infrastructure levels, because they all operate, separately. And it's understandable because the gender machinery is obviously advancing gender equality, child protection, child rights. And so I think the question really is, how can we bridge a lot of these different elements that obviously contribute to alleviating and mitigating the social determinants that impede the fulfillment of UHC, HIV, and so many other health issues. Improved disaggregation, particularly around data. So acknowledging that there is a need to include and engage with other different sectors that wouldn't always normatively engage in health. I think, especially when we look at a lot of our meetings, we don't always necessarily have BIDPA as an example, which is supposed to be a leading institution for research. And then strengthening the evidence base, particularly for communities that are left behind. If COVID-19 is anything, as has already been mentioned as one of the lessons learned, SRHR services had been shut down. And so it's acknowledging that, how do we ensure that we integrate some of these that are critical social determinants for UHC. And then integrating UHC in public health policy and programming. So encouraging reporting and obviously the inclusion of marginalized groups. And then in, continuing dialogues. And I think this is one testament to that. So I will give the audience questions, and hopefully you can be able to deliberate, on them over the next few hours. So, Botswana has held leadership, like I mentioned, with the Office of the President of the General Assembly last year, but also, is in the World Health Organization board. It will be hosting a regional committee meeting for Africa towards the end of August. And then it's got representation, obviously, knowing that the SADC Secretariat and the SADC Parliamentary Forum are headed by Botswana. So how can we leverage this strategically, particularly towards influencing the Africa Group? Because the Africa Group as a caucus in itself tends to sort of vote similarly. How can we bring in health structures and other social participation mechanisms, like I've mentioned, gender machinery or child protection committees, and even the technical working groups that are hosted under NAPA and the Ministry of Health, to ensure communities are not left behind in and beyond the 3 HLMs. And I think what was clear with the action agenda, it was that September is not the end point for that action agenda. And as a part of the task force for that the HLM working group, it was actually decided to say that the TR must move beyond just September, but to acknowledge the inclusion and implementation and action beyond the HLM. And thirdly, how do we ensure political commitment outside of political declarations to ensure communities are not left behind by policy priorities, service delivery, and accountability? Acknowledging that sometimes they can be a brain drain, acknowledging that talent can exit even in civil society. How can we ensure that we can institutionalize some of these to make sure that it's a lot more systemic and that it can be sustained? And then lastly, how do we ensure linkages within and beyond the 3 HLMs for strengthening primary healthcare, health security, and gender equity? Thank you very much.
Thank you very much for the presentation, Dumi. You've made my job easier with your closing questions. So I want you to stand there and not move away. I'd like to open immediately for any inputs or questions while they're still standing there, so that and please don't move that slide, so that we reflect a little bit, and we give you 5 minutes for interactions. Colleagues, any interventions, reactions? While you're still thinking, I think one of the key things that we need to reflect on is how, whether or not we have capacities as civil society for ensuring accountabilities, for monitoring accountabilities on the side of the state. Of course, the state will report and prepare a report to treaty bodies and all the other global policy platforms where we have made commitments. But the question is, do we always have mechanisms which allow us beyond people, which allow us to be able to continuously monitor and keep in touch with the promises that were made at the level of the political declaration and other policy frameworks that Dumi has spoken to, for example, the Africa Agenda 2063. I just want to cause us to reflect as civil society in terms of our own accountabilities. Do we have somewhere that we account? Do we have ways of collecting data and producing evidence that we account to? Who do we account to at what level? And who else needs to account at country level? Beyond the political declarations, beyond reporting, do we have mechanisms for accountabilities? Just as an example of something that we need to reflect upon. Thank you. Are we thinking? So I don't know whether we have any reflections and thoughts on how we can utilize some of these things. I think the questions are basically to spare our thinking again. So Nana wants to help us to think a little bit. Okay. Please tell us if we're pitching the language too high. I know this is all technical stuff that we don't deal with every day again. So I don't we're talking to ourselves. Please alert us so that we take it down a notch. Go ahead.
Just to appreciate the presentation, Dumi, and also just looking at the questions that you posed. They're very important questions, and then just dovetailing that with something you raised, Diane, around accountability. I think with TB, WHO facilitated for the development at a global level of an accountability framework. And the question we could ask is, did that help in then drawing down to Africa region, regionally, within the sectors, and then also at a national level? Is there some learning we can get from that to then suggest that, yes, we need one for, UHC, we need another one for PPPR? Because if you don't have that global accountability framework, then you're working in a vacuum. And so everybody's looking at themselves and thinking, you're making these piecemeal, frameworks, if at all you're making them. But when at a global level, especially for pandemics, we can all, look at how far we've gotten, what we're doing, what's in place, then that helps us to look as a collective, how we're moving the agenda forward, right? So I think maybe one of the suggestions could be, we need to develop a global framework. But I think there's also an opportunity because, the fact that these meetings are happening at the same time, there's a lot of intersectionality between the three. And so maybe what could happen is we could develop a global framework across the three that then helps support tracking to say, how do we track this at a global level? How do we track this, as the North? How do we track this as the South? How do we make sure that they're not leaving the South behind? Because a lot of the things that have been raised today have been, about equity, right? And making sure that that is practiced, right? And that there's a human rights lens to what we're doing. And you can't do that if you don't have a framework that we're working from. So that's just my 2 cents. Thank you.
I'll just quickly say noted. I group no contradiction to what you just said. I think it makes a lot of sense. But building on to that, I think the intersectionalities need to go beyond just the diseases or the issues that you spoke to, the three forums. I think they also need to, at the same time, address the intersectionalities that Dumi brought up around poverty, around SSR, around gender vulnerabilities, around positioning marginalized populations and putting them at the center. So Oh, now there's a reaction. Thank you very much.
Okay. No, mine is a very small one. It's with respect to the structures. I want to believe that if there is a response that is really structured, is HIV and AIDS, because the structures are from the bottom up, from your village development committees up to the highest national level with the National AIDS Council, National Health and AIDS Council. And when you even look at the global level, it is also very much organized. When you look at, for instance, issues around PPR and UHC, we are really struggling to be effectively engaged because the structures for engagement are not there. Is it possible for us to leverage on the HIV structures so that we can facilitate effective civil society engagement?
Not to base our responses on disease-specific issues, Agar. That is why we are struggling. Oh, Bakang was going to speak before you.
Thank you very much. So mine is basically on the accessibility of this. Okay, my name is Bakandaba from Sisonke. So my question is on, my comment is on accessibility for this UN high-level UN meetings. Like how can we enable a grassroots organization to be able to have some level of knowledge in terms of what the PPR is going to be implementing and how the UHC has an overarching in terms of some of the responses being done. So in terms of what Botswana could do, how do we then make sure that the person who does not have the capacity, like you were saying, would be able to access or have knowledge on the systems? Thank you.
Absolutely. And Dumi, I hope that you had one of the intersectionalities that I spoke to was marginalized populations. So it could be a person in the Bundus, remote area dwellers. It could be a person with disability. How do we put these people in the center and ensure that, one, they're knowledgeable, there are platforms that reach them for engagement, and two, they're enabled and capacitated to meaningfully participate. I just wanted to summarize it before passing on the mic.
Thank you very much, Dumi. That was a very wonderful presentation, and also interventions from the floor, Cindy. Okay, and also reflections from Cindy and Nana. I just want to add on those points as well. One would be really to focus on the sectionalities of the three HLMs, because one without the other would be literally meaningless, because there is a lot of intersectionality, because we're talking about health systems, we're talking about public health, we're talking about primary health care. And the more we also ensure there is this intersectionality, what Cindy also mentioned about the experience flowing from HIV, TB, malaria, Ebola, will also have a meaningful place within those approaches, because what we see within the PPPR space is a bit different from what we are experiencing. So we need to make sure that experiences against the fight, TB, HIV, and malaria needs to be captured, and those who have been actively participating should also have that meaningful representation, such as in the new space of PPPR. The other one would be also to look into the in-house policy frameworks. On the continent, we have very good frameworks that we can build upon. I'm not really pushing or running away from global frameworks and context. However, our own policy frameworks also are built on context. For example, we have the new public health order, which is now being led by Africa CDC. So let's try to influence that policy framework with the experience that we have, with the insights that we have, especially in collaborating from civil society and communities from global north and global south. Let's also try to influence such position statements. We have other initiatives such as the Africa Leadership Meeting Declaration, which is basically a health financing initiative, and health financing, especially looking at domestic resources, should also be captured here, because sustainability is equal to funding our own health response from domestic resources in addition to what we get. The other one would be the issue of optimization. I mean, there is a lot, even Dumi, you're saying that even though there is little that we're getting as ODA, or there should have been a lot actually, but we should also look at the optimization level. To what extent are those funds utilized? Are those funds burned? Sometimes we hear cases that efficiency is not within the picture. There are sometimes we still have budgets in the accounts and still we have not reached to communities out on the ground. So we should also have this lens of optimization with the discussions that we're having. But mostly I want to really point out homemade commitments, African commitments should also be seen through this lens. Thank you very much.
Very clear. I don't think I need to try and summarize that. Otherwise, I'll destroy. Do you want to respond to me?
So just a quick one. I think as Nana was sharing, she actually reminded me that, you know, the some of the decisions and the way that they're crafted, I mean, it's quite interesting. Botswana has always taken a different pathway and hasn't always gone according to the Africa group, because the Africa group always is by consensus. And so I remember with the last re-election of the Director General of so I remember even with the last re-election of the Director General of the World Health Organization, Botswana actually sort of celebrated. And then obviously his home country, as a result of the conflict, was just basically not wanting to acknowledge that. And I think we've seen it in many other democratic spaces, you know, when there's a transition in government and so forth, like there was the case in Zimbabwe and so forth with different administrations. So I think it's quite safe to say from a foreign policy perspective, there can be inroads both with the Africa group, but also as Botswana independently, at least just from having seen some of the work that has happened with other multilateral spaces. And then just around Makelemi, just to add also, I think coordination is often an issue, because I think the one thing that we learned coming out of the CSW, the Commission on Status of Women, is that, for instance, the gender unit can be, you know, the primary consultation point for all ministries, but you still find that there's an expectation that maybe Minister of Environment, as an example, will continue the work around climate change. And we know that there aren't always guarantees that gender equality will be included in some of these other more technical spaces that we are not ever a part of. And then I guess for Bakang's case, I think it's also acknowledging that there are different civil society networks, the Global Fund Advocates Network, Civicus World Alliance, the Civil Society Engagement Mechanism, CSCM for UHC, and some of these do end up sharing the information. But I think the best thing to really just say is that the information is out there. It's easily Googleable. Even if you do search the UN pages, you will see a lot of information on there. It's quite clear. I think sometimes maybe it's a little bit of admin, but I think, you know, it can take some time, but eventually at some point there can be a little bit more access as long as people are able to access that information. Yeah, thank you.
So thank you very much, Dumi, for the excellent engagement. Colleagues, I don't know about you, but for me, what is coming out is that we need to be facilitated at civil society again. There's a lot going on in what we've had so far. And I think we're all mindful and very aware that we don't have forums where we regularly engage and we can become very familiar with some of these issues. I'm sure each one of you here is itching to be able to consistently sit together and think tank and be able to push policy ideas and you know, ideas about what we can do to improve our country, and how we can also be able to monitor the commitments that we have made as a country at a regional and global level, while at the same time having spaces to be able to engage and bring grassroots communities and other communities at the margins to a space where they can contribute in a language that they can understand. So clearly somebody has to convene or lead some kind of forum for civil society for perpetual engagement, but also for ensuring that we have sustainable mechanisms for monitoring our country commitments, our regional commitments to these policy frameworks. It's just a thought, but I think it's just pointing to a very glaring gap, Cindy, that we don't have a platform for engaging. People are hearing some of these things for the first time, and they're wondering how they can, as Bakang was saying, how they can better engage from a very grassroots level, from a person who can't read and write, but they still have priorities and they have ideas about what needs to happen. I get. So without much ado, we are running behind. There's a presentation, I think it's from Stop TV. What happened to my agenda? Sorry. Oh, the one that we postponed before. Can I borrow this? Allow me to, as I said earlier, to run up to 1:30 so that we can take one last presentation so that we'll be on time from the afternoon. So I'm going to usher in the Stop TB partnership presentation on TB and addressing intersectionalities. If you are available and ready, we are starting the presentation. Okay now? Okay. So let's start.
Good morning, everyone. Thank you very much for the opportunity to join this really important dialogue in Botswana, looking at 3 upcoming United Nations high-level meetings. My name is James Marler. I work for the Stop TB Partnership. And obviously, we're from the side of Stop TB. You know, we're very much looking forward to the UN high-level meeting come September.
Yeah, Mike.
Good morning, everyone. Thank you very much for the opportunity to join this really important dialogue in Botswana, looking at 3 upcoming United Nations high-level meetings. My name is James Marler. I work for the Stop TB Partnership in Geneva. And obviously, we're from the side of Stop TB. You know, we're very much looking forward to the UN high-level meeting come September, hoping for a very ambitious political declaration, something that really reflects what's in the global plan to end TB and can put us on track to end TB by 2030. So in this presentation, I'll talk a little bit around TB and community rights agenda, just to really help, I guess, frame some of the I guess, the community priorities that have come out across at a global level, but also from partners in Botswana. I'll talk a little bit also around some of the community accountability efforts that have been led, and then I'll look a little bit at the intersectionality, I guess, between TB, between UHC, between PPPR, before concluding with some ideas about how to really ensure effective engagement and impact in the HLM process come September. So first and foremost, I think it's important to think about the idea of community rights agenda, just to really understand, I suppose, the need to, I guess, to identify human rights related barriers and gender related barriers that currently inhibit people accessing the health services that they need. Now, this is something that's directly relevant for TB, i.e. we know that these are barriers which are inhibiting us from finding the missing people with TB, but it's also directly relevant for the efforts around universal health coverage and around pandemic preparedness as well. Now, as I mentioned, like some of these TB-CRG features, like central to the global plan to end TB. That's the roadmap to end TB by 2030, but it also features in the political declaration from 2018 on TB. So it's something that very much is at the heart of what countries, including Botswana, are already taking steps to achieve in advance. I guess since 2018, there's also been really significant developments, advancement, progress in the idea of tools, evidence, and interventions that can help in TB-CRG. And there's 7 core themes here, which have been really identified as the pillars of TB-CRG. First, availability, accessibility, acceptability, and quality of TB services. Second, non-discrimination and equal treatment. Third, health-related freedoms. Fourth, the gender perspective. Fifth, key and vulnerable populations. Sixth, the participation of people affected by TB in civil society. And seventh, legal and administrative remedies, which are needed in instances where these human rights barriers are unable to be identified, monitored, or overcome. Now, significantly, I think it's important to really note that these 7 areas are directly relevant. They've come out, of a lot of processes to be understood as to what is at the heart of TB-CRG. But they're also directly relevant when we're looking at areas of PPPR and around universal health coverage. So I guess right up front, these are some areas where we can be looking at some of this intersectionality between these 3 high-level meetings as well. Now, Botswana has completed a TB-CRG assessment, and I understand as a next step, we'll look at undertaking and developing a costed TB-CRG action plan. But this slide here shows, some of those issues which have been most frequently identified during TB-CRG assessments, covering those 7 thematic areas. And what I think is really interesting is when you look at many of the issues, if not all of these issues on this slide, you certainly see things which are relevant, not just for TB, but for UHC and PPPR as well. So I think it's something that when we're looking at this important thematic area, we're also going to be thinking about in terms of why it's important for TB, why the leadership of the National TB Program in addressing these areas is so important, but also why it's contributing not just to TB, but broader health strengthening as well. So there's also, I just wanted to flag, noting the processes around global fund engagement, that this is a resource that's available that can help country partners to identify and prioritize TB-CRG interventions in your national strategic plan and in your global fund funding request. Now I just wanted to flag this as I guess something that's related to what we're talking about, even if it's not the main theme or focus of the meeting. Now, one of the things that's really seen, progress on, or one of the areas where there's been significant progress since 2018 has certainly been community-led engagement, advocacy, and accountability. And this report, entitled The Community Report of TB-Affected Communities and Civil Society, Priorities to Close the Deadly Divide, is first and foremost among these. This is the second iteration of this report, and it really is kind of a wonderful achievement to have something led by TB-affected communities and civil society to really give their perspective, their viewpoint on what it is that is needed to end TB and what it is that needs to be prioritized. It has a whole lot of legitimacy given that it's from over 1,000 TB-affected community and civil society partners. Over 92 countries are represented, including Botswana. It's 35 country-level case studies. And I note that tomorrow, on Wednesday, there will also be the Anglophone Africa launch of this report, accompanied by the advocacy toolkit as well. So this is something which I think will be really useful for both your TB-related advocacy and accountability efforts, but also your advocacy around the upcoming high-level meetings as well. So really strongly encourage you to make use of this toolkit and to really, as I guess one of the central themes and tools of your advocacy and engagement efforts for the 3 high-level meetings. Now, this accountability report has a number of calls to action. These are things that I guess are the central pillars, which we really hope to see in the political declaration, but also in national strategic plans as well. Now, I think what's significant here is they also align very closely with the key asks that were put by the whole global TB community for the UN high-level meeting. The first one looks at closing the gaps in TB prevention, diagnosis, treatment, and care by reaching all people with TB, including through rapid molecular diagnostics, TPT, leveraging the private sector. The second is around making the TB response equitable, gender responsive, rights-based, and stigma-free, with TB communities and civil society at the center. I note that in Botswana, you've completed a TB-CRG assessment, with the next step being a costed TB-CRG action plan. In addition, I note that the efforts are being done around a community-led monitoring framework, and these are 2 areas which can really help realize this ask from the community. Third, accelerating the development and rollout of essential new tools. TB innovations, TB new tools have been going largely at a snail's pace, but there's a renewed opportunity and there's a hope that by 2025 we can have a new active TB vaccine. In addition, it will be important that there's access to the existing, but also upcoming new short course regimens and various digital technologies. Next, there's the need to invest the funds necessary to end TB. TB has a huge funding gap. It is one of the biggest challenges it faces, I guess, alongside political will. But to achieve the end of TB by 2030, there is a need for 210 billion US, including 40 billion for TB R&D. This is significant amount of money when you think about it in terms of purely numbers, but it's actually quite insignificant when you look at the number of lives lost to TB every year. As part of this question of funding as well, it's also critically important to increase the funding going to communities and civil society for advocacy, for peer support, for engagement purposes as well, because we know without meaningful engagement and participation, we also won't end TB. The fifth area is looking to prioritize TB in the scope of PPPR, AMR, and UHC. So I guess this opportunity for intersectionality, which I know is part of the discussions happening today, and I'll touch more on this in a moment. And finally, committing to multi-sectoral action, decisive leadership, and accountability. And this example of the Deadly Divide report really shows a really strong step forward by TB communities and civil society to be, I guess, the guardians of accountability in this area. And it's something that we need to continue to scale up and focus our efforts on. So when looking at the Deadly Divide calls to action and the broader key asks, it will be important that you as partners in Botswana reach out to your mission in New York, to your missions, to your capital, and to really sort of see if the key asks and the calls to action are reflected in the political declaration. Things you might want to think about is, do we have numeric time-bound targets for people with TB, TB-HIV, TB prevention, MDR-TB, pediatric TB, financing and R&D in the political declaration? If not, how are we going to actually monitor progress? What is it that we're actually committing to achieve? Second, are the best quality drugs and diagnostics mentioned included within the political declaration? Third, how is the funding gap being closed? Is the funding question adequately addressed in the political declaration? Next, are some of the community priorities around TB-CRG, community-led monitoring, TB stigma measurement, etc., are they featured? Are they included? And are funding mechanisms for communities like Challenge Facility for Civil Society also featured? There are others that will no doubt come out of your country discussions today, but to really encourage the you as country partners to be advocating for the most ambitious political declaration that is possible to ensure that we're on track to ending TB by 2030. Now, in terms of the intersectionality, I think it's really important to think of TB as a metric for success in PPPR and UHC, and it should feature in the political declarations for UHC and PPPR as such. This is something, this is very much because TB disproportionately impacts those who are marginalized or otherwise vulnerable, who face human rights barriers to accessing quality services. And unless the barriers that are inhibiting people to access are identified and overcome, we will not end TB, but we will also not achieve UHC, and we will leave many at risk of during future pandemics as well. Without access to quality TB prevention, diagnosis, treatment, care, and support, it is impossible to achieve UHC. So again, this is something which is a key metric area for understanding the intersectionality with these issues. Another point that I think is really important is to reflect a little bit on COVID-19. TB systems supported COVID responses in many countries. This included the doctors, the nurses, community health workers, diagnostics, active case finding, contact tracing, stigma reduction, community-led monitoring, and so on. More investment in TB then is an investment in PPPR, especially for a future pandemic, for our future airborne pandemics, and we know that it's most likely that the next pandemic will also be airborne. Finally, UHC and PPPR must not just look at the future, they must look at existing pandemics, including for TB response that has been historically neglected politically and financially. So with all of that, I just wanted to then look at what could be done, or what's some focus areas for you as partners in Botswana to really take forward between now and September. First, to advocate for the highest level of representation from your country. Ensure that the invitation to attend the 3 high-level meetings that was prepared by the UNPGA is disseminated. Make sure your ministry is aware, Foreign Affairs, Health, and other related ministries. Second, register the country to make a formal intervention. Your mission in New York will need to do this. Your Ministry of Foreign Affairs and Health can encourage them to do that. Third, develop a pledge, a commitment, a launch for a scale-up or something new around TB initiatives in Botswana that can be focused on during Botswana's intervention during the high-level meeting. This might be something on financing. It might be around new technology. It might be on new tools. It might be on stigma. It might be on communities. There's many things, but have something clear and actionable that you can advocate for your country to be really championing during that platform and that forum. Fourth, reiterate the commitment to an equitable rights-based TB response during the HLM intervention. This includes the actions already taken, for example, the CRG assessment and the CLM framework, and also the actions that are planned going forward, for example, the CRG action planning. These are things that are really critically important and are areas which sometimes do not receive the same level of platform in TB responses, but also in interventions around TB. And so it's something that would be good to prioritize and focus on. Fifth, ensure TB civil society and TB survivors are part of your national delegation. This goes to the principle of participation and meaningful engagement, but it's also critical to have a strategic place for people affected to really be a part of the formation of the national position around TB for the HLM. Brief the delegation in advance of the high-level meeting and follow up with them after they return from New York. This is a way in which you can sort of create a sense of expectation, but also close.
Priyanka, can you hear me?
Yes, I can hear
Priyanka?
you. I lost. Yeah, I can hear you.
Hello?
I can hear you.
Yes, technology is teaching us. Can you check what's happening, Mare? Priyanka, can you hear me?
I can hear you. Are you able to hear me?
Okay. Thank you very much. There is a lull because we could no longer hear James present. The presentation was frozen. So I was asking you to please finish up and wrap up so that we can then go to the discussion, if you don't mind.
Sure, not an issue. I am not exactly sure at what point James' presentation might have cut off. So I apologize in advance if there are any overlaps or any duplications in my presentation as well. I will try to use as simple language as possible, as has been asked of me by the facilitator today. But in case I am going too fast or in case something isn't clear, please feel free to stop me and I'm happy to clarify.
Okay,
So as I said before.
Hello, Priyanka. Hello.
Hello, can you hear me?
Yes. So James was talking about what we need to keep in mind as we go to the HLM. Some of the things that we need to be mindful of, including, putting a survivor from TB or people who are affected by the disease in the delegation and so on and so forth. So they were going through those questions that could help us to prepare better. If you're familiar.
All right, thank you.
Okay.
Thank you. That's an important point and helpful. Can you please let me know if you are still able to hear me? Because for me, the screen is blank and I am unable to see anybody in the room.
Yeah, we're still struggling with the connection. I'm not so sure what the guys at the back are doing, but I think that.
Oh, there you are. I can see you now. Okay.
Go ahead.
All right. So as I said before, I am representing the TBHLM 2023 Affected Communities and Civil Society Coordination Hub today. We are supported by Stop TB Partnership and we are hosted by GFAN. And in our workings, we work as a standalone unit. I would like to introduce my team. It's just the two of us. There is Robin, who's our advocacy and policy lead. And then there's me, Priyanka. I handle the communications for the coordination hub. The idea with which the coordination hub was instated was to provide support and handholding for affected community members and civil society members across the globe to be able to meaningfully engage with all processes of the upcoming TB-HLM. So since January, we have been exactly working on this. A few of you in the room already know our work, and I know that I have seen a few of you in our calls that happen every second and fourth Thursday of the week. And for the people who are new, please bear with me as I might go into some technical aspects, but in case there are any doubts or any questions, I am more than happy to clarify as the session progresses. So James has given us a really great primer, but I just want to give you an update on where the processes for the TBHLM are right now. So as Eolin has said, and as the presenters before me have said, that over the past few months, the permanent missions in NYC, in New York City, have been debating and negotiating the language for the political declarations for TB, for PPPR, and for UHC. And now we are coming very, very close to the point where all of these three political declarations that exist in a draft form right now will enter a silence procedure. What does that mean? A silence procedure basically means that there is a larger consensus between the member states in terms of what language has been included in the draft. And if the silence procedure is not broken, if a member state does not stand up and present any kind of hitch or does not support a particular part of the political declaration then is accepted as is. So we might enter the silence procedure, and this might bring to the end the negotiation period for the language on TB in the political declaration for TB-HLM. Now, why is the political declaration important? The political declaration is an end product of any high-level meeting. It is an accountability tool. It is a declaration that all the member states come together and sign and endorse, and hence for us affected community members and civil society members, it becomes a tool to hold our governments accountable. 2018 was the first HLM on TV, and we had very high targets and a very promising political declaration that came out of the 2018 TBHLM. But unfortunately, the targets were not met. There was very little progress that was made towards the targets that were set in 2018. So our hope was that this year's political declaration will not only learn from the 2018 political declaration, but also build upon it. But unfortunately, when the first draft came out, we saw it as a subpar draft because it did not build on the 2018 declaration. And in fact, a lot of language and a lot of strengthening pillars that were there within the political declaration in 2018 had now gone missing in the 2023 draft. So the draft was very weak. It was a clear step down from the 2018 political declaration, and there was a lot of non-committal language around we will strive to, we will try to, will try to achieve, were the kind of language that we were seeing in the draft instead of we commit to, or we promise to, or we will plan to. So which was a problematic first stance in itself. Add to that the fact that there were very few numerical targets that were included. Now, why are numerical targets important? Numerical targets and goals are important as a key accountability tool. We need numerical targets to hold our governments accountable and ask them to take concrete action plans in order to be able to achieve set numerical targets. Without numerical targets, it's a very weak political declaration. Now, there have been many gridlocks with negotiations between the member states and the politics between the different member states, but the community members from across the globe have been very active and proactive in working with their heads of states, working with their ministries, working with their country missions to ensure that the language in the political declaration is changed and is made better. So currently, where the political declaration stands, we are able to get some numerical targets in there, but not to the extent that we had expected. And if the political declaration enters the silence procedure, that is also should not be immediately looked upon as the end all situation, because member states can break silence and bring back to the table any particular part or section of the political declaration that they do not agree on and they want to make amendments to. Apart from this, the invitation, as James has said, invitations to the heads of states have been issued by the President of the General Assembly for all heads of states of the member states to attend the UNHLM in person. I'm just going to reflect on the key community asks that we had wanted to see the political declaration. These are things that James has already mentioned, so I'm not going to spend too much time, but only just want to tell you that of the key community asks that you see on the screen from 1 to 5, there have been very few inclusions in the current political declaration. But does this mean that this is an end and we can't do anything at the country level? No. So I am circling back to what James has said. There is still hope and there is still action to be taken at the country level. What can we do at the country level to ensure the community members are meaningfully engaged and that we show up with strong voice at the UNHLM? One, we need to ensure that our national country delegation includes a member of the civil society and of the community on the delegation itself. The modalities resolution of the UNHLM, which is an official document, which is available on our website, I will give you the link, but The modalities resolution officially states that member states are encouraged to ensure that a person from the affected community, from the civil society, is a part of the country delegation. So we need to rally our forces and talk to our heads of states, talk to our external affairs ministries, talk to our ministries of health, and ensure that not only are our heads of states, be it the president, be it the prime minister, attend the UNHLM, they attend the UNHLM alongside a representation from the affected community. Because it is not acceptable that we are kept out of the room and that we are not a part of the conversation that affects our lives the most. Then, what else can we do? Ask for commitments beyond the political declaration. In September, when we are showing up for the UNHLM, that is a more ceremonious presentation. The political declaration will get finalized before the UNHLM. It might get finalized by the end of August. It might get finalized the first week of September, depending upon if the silence procedure is broken or not. But as presenters before me have said, and raised a very valid point, that the true interventions happen at the national level. We might commit to things at the global level, but what we need is action at the national level. And we need our governments to show up at the UNHLM with a strong commitment to end TB at the national level. Something new, something innovative, something novel. Or perhaps an increased investment in already including plans or actions that we have at the ground level. Why does it make sense to push for something like this? Because the UNHLM, at the end of the day, is a political platform. And this, a strong commitment coming from our countries at this highly political platform, calls for not only a raising of the nation's value in terms of their commitment to ending TB, but also gives us, the affected community members, to later on hark upon this and ask for accountability and ask that these commitments in fact be fulfilled. In case you want more information or are looking for resources in terms of how to start these conversations with your heads of states or are looking for any guidance, you can reach out to us. As I said before, we have deep dive calls every second and fourth Thursday of the month at 2 p.m. CET. Link for the registration is available in this PPT deck, and I will ask the facilitators of the meeting today to circulate this PPT deck widely amongst all the participants so you have access to all the resources. Apart from that, let us know the coordination hub in case you are planning an event or a side session at the UNHLM, and we can together try and figure out how maximum amount of support and attendance can be made available for your site-like events. What is the hub doing at the moment? We are engaged, we are knee-deep in, looking at the current content of the political declaration and trying to figure out how much or to which grade our key asks have been included in the political declaration, and to be able to make heard the fact that we are unhappy with the current state of the political declaration and not all of our key asks are included. We soon will be launching a global statement, and I encourage you not only to sign on to that statement but also look to use this tool, this I'm sorry, my words are leaving me, but look at this tool and think about what you as a conjoined coalition of affected community members in the country can do to perhaps launch a similar statement. Just to circle back to something that James has already mentioned, and so has Olin, the HLM registrations are open. You can register for attending the HLM in case you have the ECOSOC status till August 11. And few organizations have also gotten a special accreditation to attend the UNHLM, you also need to register the name of one representative from your organization who will be able to travel to New York and attend the UNHLM in person. In case you are unable to, you have a special accreditation, but are unable to support a person with funding to reach the UNHLM, please don't run to register the name of a colleague, of a lead of an organization right this moment. Please let us know if you have a seat that is available, that is free, and we will try and work to provide that seat to a community member who might have funding secured. On the other hand, if you are a person who has funding secured to be able to travel to New York, but do not have an official registration to enter the room and actually be a part of the UNHLM, then please also reach out to us and we will try and coordinate and see if there are seats available among other community members and civil society organizations that might be available for people who have funding secured and are not able to get a registration spot. To this effect, we have a small survey, and I will again provide the link. Please engage and fill out the survey. It's not a very long survey, but this will give us information to be able to connect people and ensure people who have funding do in fact actually get to attend the HLM. One other thing that you can do to take action is to mobilize and take part in the International Youth Day campaign that we are currently running. As we know, the 12th of August is the International Youth Day, and we are calling this campaign Youth Power for TB-Free Future. The idea is to call upon our heads of states to attend the UNHLM, and not just attend the UNHLM, but attend the UNHLM with community representation and with strong commitments to NTB at the national level. The green tile that you see on the screen right now is the kind of campaign materials that are available. We also have, in terms of templates, the red slide that you see available for you to take on, change, adapt, design as you might feel fit to join in the International Youth Day competition, in the International Youth Day campaign. And the third most exciting aspect of this particular campaign is that we have a social media visual competition running. There are cash prizes to be won for this competition, and we are calling on people who are young and young at heart to take a part in this social media visual competition and create your own GIF, meme, infographic, whatever your creative heart desires, and post it on your social media and tag us at GF Advocates with hashtag 2023 TBHLM and hashtag YesWeCanNTB. And this will run for the entire month of August, and then we will be announcing the winners of this competition in September as we lead up to the UNHLM. And as I said before, there are cash prizes to be won for this competition. So that's the end of my presentation. In case there are any questions or a need for me to repeat something, I'm here. Thank you.
Thank you very much, Priyanka. We are just about over the lunch hour, so sugar levels have gone down. But I wanted to do justice because you waited for a while we were putting in other presentations. So I think, just to be fair, colleagues, let's accord Priyanka interaction. It's hard to ask. If there are any comments or reactions to their presentation, I'd welcome just a few. But what seems to be coming out to us, Priyanka, is that there's a lot more organizing around TB that needs to happen within the country. I see you, Cindy. Generally, we see a declining interest in in the TB response away from HIV, as well as declining interest in resourcing or funding TB. So it's not really surprising to also see very little interest at the high level, including weak language and very weak commitments. So I think country level or regional level, if there's anybody who can revitalize, particularly civil society and affected populations, I think it's quite clear that this is not just a Botswana situation or an Africa situation. We need to revitalize and put energy back into the global TB response. So I'm even glad that you are highlighting that these commitments, or we need to pin down governments to make commitments even beyond the political declarations, because we have a situation, and I think we need to really revitalize the global TB response. I'm going to allow Cindy and Nana. Who else? Yourself? Okay. So 2 interventions, and then we go for the lunch break.
Mine is not an intervention. I'm just using the powers vested on me by the government of Botswana to request that Dr. Molefe, who is the National TB Program Coordinator, to maybe give us a brief update about what is happening with respect to the TB HLM, if at all there is any. Thank you, and I apologize in advance.
No, that is serious abuse of powers vested on herself.
Serious abuse.
But go ahead, Doc, if you have something to say.
Good afternoon, colleagues. I'm Dr. Molefe from the TB program, and I had asked Cindy not to put me on the spot, basically because at national level currently, there isn't very much going on in terms of preparation for the UNHLM meeting in September. Or at least at the program level, we have not received any communication to that effect. And I think this is pretty worrisome given our TB situation in the country, because we are also not meeting targets that we are expected to meet that were set. Am I not audible? What I want to make my purpose, because I'm speaking quite loud and I'm speaking into it. As I was saying that we hadn't received any communication as with regards to preparation for the UNHLM in September. And it's worrisome from the program point of view, because Botswana is one of those countries that made commitments to 2018 UHLM. We have not met targets, while HIV on the other hand has done extremely well. TB has been left behind. And so I think we have a lot that needs to be done as far as the commitment to TB. And I am looking forward, Cindy, with your intervention, to receiving something that will prompt us, to getting that momentum going. Thank you.
Thank you, Dr. Molefe. And just to pop in a question in there. So if nothing much is happening in terms of the ministry's preparations, what kind of support will you welcome? Obviously, you can see that civil society is up and about. What kind of engagement and support prior to the HLM would you welcome as the ministry and the BNTP in particular from civil society to perhaps help you to invigorate your preparations and or at least to do something that you can pitch to peers from TB?
I think from at program level, what we need is a lot of advocacy for TB. And I'll say it here because I believe we're within closed doors. TB funding is reliant solely on Global Fund. And without government supporting the TB program, it just goes to show you the commitment that's there at national level. So I would really ask civil society here for some advocacy. I don't know what you're able to do, but advocate for more visibility of the TB program, more resource allocation from a government point of view. That way we will start seeing more interest, I believe, from government and the ministry at large.
Okay. I think we can talk more about what we can take to the HLM, I guess. If you stick around until in the afternoon, Dr. Molf. Okay, so we can help you if you're not there. But colleagues, there's obviously a glaring gap. Nana, I'm going to have to forgo your hand. There's a glaring gap. When we come back, so TB is a problem. TB is struggling globally in the country. So what can we do? I want to shut this discussion down here. I think I've gone beyond stretching your patience and request conveners that we break for lunch and beg all of you to stay with us in the afternoon. Please, please, please. So coupons have been passed around. Please go and eat and refresh and come back. Oh, what time is it now? Okay, so we're going to break for lunch. We didn't have any questions for you, just a reflection at a country level that we're also struggling as a country. So we'll come back at what time? 2:15. Okay, we'll come back at 2:30 and hope the afternoon will go faster. Thank you very much for your patience and your engagement. Yeah, lunching. Are the people still online? We have people online again? Sarafina? Oh, welcome, Mamuna Metsi and Mandla.
Thank you, Dana.
And welcome back, Sarafina. So, colleagues, can we settle down so that we start? I think we're going to be late again through our own doing. Radikang. Gara. Okay. So I believe that we had concluded just before lunch on the presentation on TB intersectionalities. We realized that there were many issues that we need to address, first and foremost, at the national level before going to the international policy landscape. I also want to note concerns from partners here, also noted by myself that we have pitched this dialogue very high in terms of language. The content, there's nothing we can do about it. It's about the HLM preparations and documents. But I think we need to appreciate that we have communities among us. We also have ordinary colleagues who might not have been dabbling in the space that we have been in. So the language is quite unfamiliar and a bit complicated and poetic. So this afternoon session is a panel discussion. I believe that we can talk like normal people. Normal people are ordinary. So I believe that we can bring the language down to the people that we have really called here, who we need to put at the center. I think we are just paying lip service if we continue to talk the way we talk. The community, and we're putting them at the center. So Radumalana care about bringing the language a bit down. Whoever is going to comment from the floor, facilitators, panelists, let's all agree to talk as we talk when we're having the beer. Again, in language that everybody can follow. So without much ado, we're moving on to the next session for the afternoon, being the panel discussion on the 3 HLMs, unpacking political declaration, breakthrough, gaps, and recommendations. I call to the panel stage Dr. Mfokeng from the Ministry of Health. You are on the program, the one that has been before you in all morning and you did not refuse. Please come to the stage, Doc. No. I'll call to the stand or to the, not to the stand. I'll call to the stage Nana Gleason from BONELA. He's already sitting there. We told me to go below her fate. I'll call to the panel Watch Health, Waki Health, Fitsum. You know what I've learned about working in this space? When you don't know people's pronouns, never ever try and guess them and say Mr. or Miss. Just call people by their first names is okay. I get that is less offensive than calling misgendering somebody. So Fitsum, it's not out of disrespect, it's out of respect that I call you Fitsum because I don't know your pronouns. Yes. I call my friend, my dear friend Dumi. I'm advertising Gallo Palacio. From Success Capital, I've been doing that all morning. Hugs and endless kisses and telling them how beautiful they are because Kawata Songonya. Dumi? All right, so I believe that we have everybody that we need to have. I don't have guidance before me, but I believe that Cindy will be moderating the session. So over to you, Cindy. Please start by explaining to us what this is about. I believe you'll do that. Thank you.
No. Thank you, Diana, for the opportunity. Let me take this opportunity to welcome our esteemed panelists. I will try as much as possible to bring down the language of the conversation so that we can all be at the same level. I'll try my best. That's all I can commit to. So this is a panel discussion that is really meant to unpack the political declaration. I want to believe that all of us have had an opportunity to read the 3 documents, which are the point of reference at this particular juncture. So we want to understand what is coming out of those documents, what we think are the breakthroughs, what we think are the gaps, as well as recommendations. So I am going to pose a question to all our panelists. You've read the political declaration document. What made you jump for joy as you were reading all the 3 HLM documents? I'll start with you, Ms. Gleason. I don't know if it's jump for joy or jump with joy.
So, thank you and good afternoon, everyone. I'm not sure that I can say across all three declarations, I was jumping for joy. I think earlier on in the day, Priyanka presented, specifically on TV and indicated already that, it's quite a weak declaration. In fact, it's digressed from 2018 political declaration to now. And so I think for joy to happen on that one, there needs to be a lot more progress. I think we can appreciate for the PPR, it looked like there was a lot of thought that went into that document. Despite the fact that, Cindy, you had indicated that coordination and mobilization around it wasn't as strong and as concise as it needed to be. It seems with COVID and with the stark realities of what happened to the world with COVID, there's a lot more interest at a global and continental and regional level to make sure that, countries are able to manage pandemics going forward. Oh. You can't hear me at all. Technical issue. So you couldn't hear, I have to start again? Oh, it's okay. All right. So basically, lost my train of thought. And then with the UHC, what the declaration is doing, for the most part, is trying to incorporate quite a lot of other issues that should really be very specific in other disease-specific declarations. While that's good progress, there's also the chance that we will lose other specific considerations like what Priyanka talked about for TB and, even HIV. I know it's not the HLM for HIV, but, when you put all eggs in one basket, so to say, there's often a possibility of forgetting really specific things that must constantly be reiterated and buttressed and ensured that specific resourcing goes to those things. So yeah, I was excited, particularly for the PPR one. I think there were some good elements there, even though I think later on in the discussions, we'll talk about areas that still need improvement, especially around some aspects of equity. But for the most part, I thought that it was a good declaration. Thank you.
Nana, Fatum, to you, you have a regional perspective to issues. So when you look at all the three HLMs, is there anything really positive that we can build on and maybe, be able to provide the best healthcare to our people?
Thank you very much. Yes, definitely. Well, looking at the three HLMs, as Nana already mentioned, we could have done better as a region and also as the African group. However, what I would say was very good, or that maybe that thing that would make me jump would be the African Common Position on PPPR, which came in a very needed time, because here I believe there are also other lessons that we can learn in terms of how we can mobilize African governments, African civil society to it. Yet there is that process whereby we need to look at the common position and also make our inputs to it, but it is very much positive and welcomed that we have an agreed framework for a common position for pandemic prevention, preparedness, and response. And that has been also supported by a communication and negotiation strategy, whereby it also guides member states in their negotiation. So I believe looking at the three HLMs, PPPR would be the one I would say we have done good in terms of the African continent.
Thanks, Fitzim. The same question to you, Dumi. Anything exciting in the 3 documents? I think you have your own.
Am I clear? Okay. I think for me, it's really also around the processes before even speaking about the actual documents themselves, is that at least this time, there's a little bit more openness, there's a little bit more access to information. And I think there's a lot of coordinated efforts by civil society to make sure that it can reach communities. I think for me, that's the one biggest difference. And more importantly, that the engagement. And so I think it's really helpful with the fact that it's actually even useful for member states with some of the feedback that we got in terms of advocacy, where some member states in their own conversations were able to use. Okay. So I think, yes. So I just highlighting that the process in itself was a little bit more open, that there were more actors that were engaged in the process, or there was a little bit more awareness raising around the different declarations or the HLMs, and that there was concerted efforts from civil society to make sure that not just other civil society actors, but also governments are aware of the developments that are happening. And I guess more importantly is that in between the different versions, there's insights that's shared where there is surveys that are being carried out in terms of actually gauging on whether civil society and communities are included. But I think something for me that maybe has been a little bit prominent is addressing equity and making sure that to leave no one behind. I think those two are the most prominent. And I think to some extent, even though there are no specifics, is speaking to financing as well, acknowledging that there's a need for improved financing across the health landscape. And then the last one is now seemingly having more of a focus on national level because of the need for political commitment. Because I think sometimes when the reliance is on like the 2019 political declaration where, oh no, it was at a global level, then a lot of people felt absorbed and not necessarily responsible to try and implement and make sure something happens in country.
Thanks, Dumi. And I want to pick on what you said, which is basically a guiding principle for all the 3 HLMs, which is equity. Sometimes we try and say the right things, like being politically correct, without necessarily breaking down or going down to what that really means, especially from an actionable point of view. So we see all the 3 documents speaking to equity. From a civil society perspective, are we satisfied with the way equity has been pitched? And are there any recommendations that we can make which can bring out some tangible actions around equity?
Thanks, Cindy. And that's a really important point, because we have to move from rhetoric to action. I think for me, in thinking about what are the gaps around equity, I particularly focused on PPPR. So I'll talk to some of the issues there. And I think Elon spoke about something in that regard, which is basically around the fact that the declaration says, going forward, countries will provide their genomic data, and then it's voluntary whether then they'll have access to the product afterwards. Equity means everybody will have access, right? And particularly those who have contributed to that solution. So, we need to look at things like this. There's also a gap around clinical trials and using the principle of good participation practices just to make sure that the regulation is streamlined and it's conducted ethically. There's also a gap around manufacturing capacities and strengthening through licensing and technology transfer. It has to be there, it has to be explicit. There's also not much being said around using the principle of global public investment, which is basically all contribute, all benefit, all decide. That if we're meaningfully engaging communities and all relevant sectors, that's how it should be. As much as, yes, sometimes we often take the default that no, but African countries don't have money, or countries in the global south don't have resources. Resources are available for what things people prioritize. So we basically have to do advocacy to ensure that these issues are prioritized and that adequate resources are put to it, even though it may not be to the same level. It has to be there. And the declaration should put words or articulate that so that governments are already prepared to put those relevant resources from domestic pots to this. And then also around ensuring, I mean, one of the things I was happy about was that there's financing being put aside for PPPR, which is really important. And that's being done through, WHO and the pandemic fund. But why don't we utilize platforms that we know are there and that already work to get resources to communities like Global Fund or any other ones, right? So we need to not move away from what has worked and really capitalize on what has worked to make sure that we continue being equitable and using platforms where we know rights are recognized. Yeah, so let me end there and then I'll let Fitsum and Dumi also contribute. Thank you.
Yeah, thank you, Nana. Thank you very much for that. Fitsum, I think the same question for you, but looking at it from an Africa regional perspective, what should countries, including Botswana, be pushing for specifically when we are looking at issues around equity?
Thank you very much. I believe within these negotiations, context really matters. And we need an African context and an African narrative in these conversations. Otherwise, then we will be misguided in some of the decisions or the negotiations that are happening. Yes, we have some wins, but also we have other areas which we have not secured a global commitment. Just to look at the political declaration analysis on TB, let me just point out to 1 or 2 points. So there was a key ask, 4.2 subsection reads, US 13 billion should be made available annually to vaccinate people with new vaccines once they are available and conduct necessary implementation research. We have not secured this commitment. Another commitment is to ensure that all countries contribute their fair share to financing TB research and development. We have not secured this. And looking at the regional disparity, Africa is the most affected when it comes to TB, and also basically the three approaches. But these are areas we need to have put more concrete push, more concrete solidarity within the African group to at least have these commitments kind of being realized and committed to. Yes, we have some commitments whereby there is open space for civil society and communities to participate, which is a very good start. However, looking at 2030, looking at the gap, and looking at also what we lost during COVID, we need to double up in terms of pushing the best that we can in mobilizing governments, mobilizing civil societies, and also pushing back. Political declaration is something that also is left for implementation after it's been endorsed. So there is also opportunity for us to kind of continue. For example, we can do a national advocacy looking at the different missions we host. For example, the G7 missions, the G20 countries. We can also have bilateral conversations that we can facilitate. Well, Ministry of Health can participate, Ministry of Finance can participate, civil society, affected communities can also participate and look into these commitments which have not yet been honored to see what we can do as a region, but also what we can do as a country and as a nation. Thank you.
For you, Dumi.
Thank you, Makelemi. If you will allow me, I'd like to do a quick poll with our audience. So how many people feel like women and girls are a priority in the high-level meetings that we've been speaking about today? Please raise a hand if you agree that women and girls are a priority group. So I've got what, four hands? Please raise your hand if you feel like women and girls are a priority group across the 3 HLMs. Okay, so I will say maybe 40% of the room, less than 40% of the room, which is a bit opposite what the 3 HLMs speak to, because they prioritize women and girls. And so then the question now is, even those who didn't raise their hands, how many people included trans women as part of women and girls? Please raise your hand if you did, whether you said yes or no. Okay, so even less. And so I think to answer your question, Makelemi, it's very clear. Equity needs to be very specific. That's one of the reasons why we're not just saying equality, we're acknowledging that there's a need for equity because there are groups that are left behind. So I don't think equity can be achieved if it continues to be abstract, right? And if it's not specific. So aside from that, there's still very little talk or narratives around, for instance, people living with HIV. There's very little talk around people in prisons. There's very little talk around migrants. And I think it's very clear that a lot of these groups are already excluded just from the ambiguity of structuring equity as it is. I will also then flip it and say that ambiguity also allows us to include these left behind groups. Because after all, it is a political declaration and it's not necessarily legally binding like an international instrument, like international law. But the ambiguity at least allows civil society to sit and say, but we're acknowledging that there are diverse women and girls. We're acknowledging that there are women with disabilities, that we're women from indigenous groups. And so I think for me, it's both a bit of a cloudy scenario, but there is a silver lining in that at least we can push to advance. I think the one thing, because at least there were specific mentions of the other HLMs, specific to UHC, what I think is great is that they can be specific enough in terms of certain elements that need to be touched on. So substance use as an example, like there are very context-specific scenarios that have an impact globally and nationally. And I think that gives us an opportunity, especially where we don't have the evidence, to then build that evidence because it has been recognized globally.
Thank you so much. Maybe at this point, allow me to bring in the issue of accountability, because when you look across the 3 HLMs, it's also a thread that is running through. But it's not particularly clear to me the accountability mechanisms that are proposed. At least we know that, of course, the high-level document just provide indeed high-level guidance, but implementation rests with specific countries. But when you look at the document itself, does it put enough emphasis around accountability mechanisms? And does it also help in terms of guiding what are some of the actionable things that we can do to actually ensure that there is accountability? If you look at the African context, I think we are really struggling with issues around corruption. So when you bring issues around corruption to an already ailing health system, then it basically means that you have the disaster in your hands. So how then do we ensure, especially from a civil society perspective, that we actually have mechanisms in place that will ensure accountability for implementation, for governance, and everything else that is the HLMs? You can start, Fitum.
Thank you very much. It's a very important question, but also I might not have the direct answer to it because it's very much left for interpretation. at country level, and it's very much also left to capacity in terms of the implementation. However, just looking into the three HLMs, maybe starting from the HLM itself, I would say there is a better accountability mechanism for UHC and TB. However, looking at PPPR, rather also being a new kid in the block, there is some room to improve that accountability process. For example, for UHC, there is the UHC 2030 engagement mechanism, whereby also civil societies can follow up and hold the UN and governments accountable. For TB, there is a Stop TB partnership, which is a very strong partnership, really looking into the details and seeing how that will be implemented. And there is a very good follow-up. And it was also one of the success stories of the May engagement in New York, whereby Stop TB facilitated a visit to 49 permanent missions in New York with all the asks and the documents. When it comes to PPR, there is no specific civil society engagement or acknowledged civil society engagement mechanism. So it's just a group of advocates who are very much interested in that space, who have organized themselves and advocating for these questions and also looking for to see how accountability is ensured. When coming back to member states and to countries, I believe since it's a political declaration, the interpretation might not be the same between Botswana and South Africa. The context is not the same for Botswana, or maybe let me say a relatively smaller country like Djibouti or Eritrea. So there is a lot of local context that will determine to what extent this political declaration and also the commitments will be interpreted. However, we can have a common approach as a continent, whereby at least we should have a regional and national implementation strategy, whereby we have civil societies as part of the monitoring, evaluation, and also implementation with that capacity in the process. So at least from there, we can ensure that the national level and regional level accountability can be ensured. We've mentioned about corruption and such, but usually there is also another problem of inefficiency within our systems. As much as we're afraid of, or we want to fight corruption, and efficiency sometimes is equal problem to most of our processes. So just recently, I've also heard from my country, Ethiopia, there was around 133 million local currency Ethiopian birr, which was not utilized. And according to our fiscal calendar, the year is already ending. So all this money could have gone out, made value, and also really assisted communities and civil societies and citizens. So the first thing would be to come up with an implementation strategy with it costed, looking at the timeline, looking at the commitments, and also very specifically making sure there is a division of responsibility whereby government, civil society, implementing partners, and also donor countries will have their own stake. So if we can come up with this kind of methodology and approach, at least we can further ensure there is equality in that implementation. Thank you.
Absolutely, thank you. Nana, you want to go next?
Yeah, I just wanted to say beyond the points that Fitsum has made, the PPPR declaration actually has a section around leadership and accountability. So I think the opportunity that countries will take and also through civil society to support that accountability is to look at those sections and to then translate that into saying, okay, let's put milestones in place to see how are we progressing as countries against this, because they're quite broad statements. And I think also in line with what Priyanka said, where the wording is not so committal, but it's there. And I think that's the beginning. There's section around national ownership and the primary role, the responsibility of governments. There's a section which talks to what you talked about earlier on, Cindy, around strengthening legislative and regulatory frameworks. All those laws that hinder progress around this issue, we need to deal with them as a country. And you can draw down from these sections of the political declaration. It also talks about embedding a multi-sectoral emergency coordination response. And this will be underpinned by disaggregated data, analytics, looking at potential health threats and monitoring. And so I think it's a really good start in terms of having at least 5 basic areas that will hold, the leadership accountable around this issue and countries as a whole. And then the idea would be for people to recognize which part they play
and how they can contribute. Because at the end of the day, accountability is across the board. We can't just say we're holding so-and-so accountable. We also have to say, what is it that we can do to support this as well? Thank you.
You also include civil society, that we also have to be accountable. And what are the mechanisms we are going to use to hold ourselves accountable? Accountability, if you could also, speak to it in reference to accountability for vulnerable, key and marginalized groups.
Thank you, Makeleme. I think for me already, when I think about accountability, the fact that a lot of communities are already not counted, that says a lot, right? So when we talk about who are you accounting to, for many instances, it's always about the financial, right? To say this much has been invested, we have spent this much, is it efficient or is it not? But when we talk about the users or those who have to then access services, we never think that we have to be accountable to them. Even as civil societies, what does that look like when we're talking about being accountable to the community as DHMT, District Health Management? What does it look like as a community volunteer, right? Do you just end where you're giving travel reimbursements, or do you also, or are you also included in the continuum of care when you have to refer someone for services? And so I think for me, the way that I understand accountability is that it currently is inefficient, because we already know in many instances, a lot of leaders are not always accountable because they've been absolved from electoral promises. And one of the reasons in this current climate around anti-LGBT issues is because that is one of the forms of distraction from accountability for service delivery. You know, where there's inadequate services being provided, unfulfilled electoral promises, that then means that LGBT people are used as a scapegoat, especially knowing full well that Southern Africa will be having quite a lot of elections over the next 2 years. And so I think for me, it's then sitting within this context and saying, now we want all these heads of state who might be in power in a year or not, come and sit there and say, yes, they want to commit to accountability. The 2019 political declaration on UHC already had accountability. And we've already seen what that means if there's no legally binding instrument. So I think, yes, it's encouraging that there is provisions for legal and legislative improvements, but I think, and I guess this is because of the different contextual differences, but I think something that had been mentioned about different country contexts, and for me, I am reminded, like for instance, when we took part with the African peer review mechanism, you know, you had a scenario where we had to engage communities and find out, are you really getting service delivery? You know, are you accessing your services? And so for me, if it means that you can't participate at the voluntary national reviews because your country didn't submit a statement, then we know that Congo was actually facilitating something and we could have contributed to a chapter. If that doesn't work, then we know what, you know what, the Universal Periodic Review, Ghana CIDAW, will come up, and maybe it might not be health focused, but we can definitely put our community's concerns there. Because now government will have to confront the questions because it is legally binding. So I think for me, it's also a double-edged sword in that, yes, in as much as it still doesn't commit certain percentages, certain statistics that you can count, even though the challenges that are identified there are quite specific. It really says, for me, it says a lot about political will. What does that mean if our leaders can diagnose the issues that we're facing, they can articulate them globally and nationally, but they can't articulate how they will address them with the same level of specific data?
Wow, I think that's a mouthful. And it's really, really interesting. So I want us to move to climate change. Again, across the HLMs, it is clear that if we don't make concerted effort to address issues related to climate change, then we may not be able to achieve anything around health. So in your assessment, do you think that the documents have positioned climate change in a way that would really facilitate for us to address those intersectionalities, but also ensure that there is collaboration and partnership with those players in the climate change space? You want to start?
Thank you, Michael. If anyone commemorates International Youth Day, they will know that the current theme on 12 August will be green skills for youth. Yes. If you may allow me one last poll. So please raise your hand if you can directly link climate change to health outcomes. Okay, a bit better than before. So yes, so I think we know that climate issues have been quite dominant, and it's great that to some extent the room is reflective of a lot of global political leadership, because we know that there are still some states or some political leaders that deny climate change, or some interests that deny climate change. And so I think for me, in acknowledging that the World Health Organization recently reported that climate change is one of the biggest risks, right, coming out of the pandemic, but one of the biggest risks to health. And so what does that look like for those that maybe, might not know? If there is a change in a harvest cycle, like it's delayed, Botswana recently announced a drought season, if I remember correctly, a few weeks ago. That means that nutrition is impacted. Increased heat temperatures have been scientifically proven to have links to compromising mental health, even compromising maternal health. And so I think if we're not alive to these issues and acknowledging that there is an impact on climate, then there can definitely be shortcomings in what we do when we're implementing and when we're actually trying to review and call for accountability. The other element for me, what's important is in trying to maybe then bridge the different issues, because climate change, adaptation, mitigation is a different school of thought that many civil society and communities are not a part of. And we also must acknowledge that we've got indigenous knowledge systems that are able to navigate climate change, but maybe aren't always recognized in the context of health as well. And so how do we bridge these different integrated schools of thought, because they are representative of certain communities? And if we're saying we're going to leave no one behind, I think there's a need for us to make sure that we incorporate climate change around the SRHR, whether it's around the HIV and non-communicable diseases. So I think it's an opportunity for that, just acknowledging on the bright side without bringing all the challenges and shortcomings of the 3 HLM drafts.
Tim, you want to go next?
Well, I would say Dumi has concluded in a way, just maybe to kind of put more emphasis on what's already being said. So climate change encompasses or kind of triggers other behaviors within society. One would be migration. Within that, we're talking about health system strengthening, health systems. Within that, we're talking about communities, resilience as well, moving from one place to another. And here also, it was mentioned this morning that when also there are these movements, then there are also instances where vectors or diseases also move along borders. So this is also a very important point, I believe, to raise and to kind of have a holistic approach to. We're talking about the Africa Continental Free Trade Area Agreement, whereby we have member states of the AU who have signed to open their borders for trade, to facilitate trade. And within this, the effects of climate change in terms of antimicrobial resistance and looking into the other possibilities of movement, we need to make sure that apart from the political declaration, our national health system strategies should also be flexible to these. One of the things also, we were part of the African Union Summit in Nairobi, and it was on facilitating the African Continental Free Trade Area Agreement. And one of the things we were discussing is also how to have a regional database centers, whereby we have data of each African citizen, whereby every country can have access. I might be traveling, I traveled from Ethiopia to Botswana. Let's say something happened to me and I was not in a position maybe to respond to a physician. How would they know my blood type? How would they know if I have any history before that? Then how would they rightly diagnose and prescribe the medicine that I need for? What if I forgot something, one of my medicines or capsules somewhere, and there's no way that they can address? So it has a long reaching impact, and we need to harmonize most of our policies to address this, because climate change didn't come for Botswana or South Africa. It's a global problem, and Africa is adversely actually being affected by it. So we need to make sure that our policies look into this and must be flexible to accommodate. So yes, maybe the high level meeting, the political declarations can do better in this regard. And I believe looking into especially the PPPR and TB, I know there are some mentions about it as well. However, it's still a political declaration. This is a political declaration. The implementation is left for member states. So we need to understand that. And as Dumi rightly mentioned, we need also to make a cost of other factors whereby we can utilize every knowledge and experience as much as possible. Thank you.
Thank you. Maglison.
They've both said a lot, but I think, yes, absolutely. It was important that climate change be included. To the extent, though, I think, like Fitzum has said, it's not enough. I think in the PPPR, there's a paragraph around it, but it doesn't, go to specific levels. Again, it means it's arbitrary how countries interpret it and what that translates to in terms of implementation. But I think just looking at the principle of One Health as Botswana, as countries in Africa, we need to recognize that climate change is a real issue and that it has an impact on every kind of health situation. And so as communities, it's our responsibility to understand what that interconnection is, so that even as we program, we're programming with that in mind. I think Dumi gave some examples. I mean, the recent floods along the whole side of Africa is an issue. What happened to all those people? I mean, imagine you are a woman in a camp, you need access to SRA services, there's a river that has formed because of the flood, there's no availability of that. These are basic things that need to be recognized, and it's a huge impact on health. There's also not enough resourcing being allocated by countries, but guess what? Climate change as a global issue is huge. There's huge amounts of money being allocated. Only gets between 4 to 7% of that resource. The rest goes to other countries. That's because people don't actually understand and appreciate what the connection is. We need to be able to advocate when we're in these right spaces to say more money should come to mitigate potential impact, because we know some of these cycles, people are actually doing trend analysis for them, and they know that this is possibly coming or may come. And so we need to be more proactive instead of reactive, and actually allocate resourcing to this and appreciate how it's connected to health. And so we should stop working in silos, and we should see how to, work together to basically also access some of those resources that would help health and advance us, because improving one will improve the other. Yeah, thank you.
Thank you, Nana. And maybe as I'm drawing towards a close in terms of questions posed to the panelists, so that we can engage our audience as well. There is this question of health system strengthening, resilience of health care systems. And I just want to check with you if in your reading and assessment of the HLMs, if you think that enough attention has been put on health system strengthening, and also bring in the issue of community systems, because in most cases when we talk health systems, we talk about it at the exclusion of community systems. But I want to argue that in my view, it's one system that is operating at different levels. So do you think those synergies have been highlighted well enough to the extent that we can be confident that our leaders will give us a document that will provide guidance to countries to further implement programs that are geared towards community systems strengthening as well as health system strengthening?
Sorry, thank you, Makelemi. I think, yeah, I forgot the last part of your question, but I was also just thinking about how countries are very, very different in terms of their health systems. You know, when I think about South Africa and how social participation is quite prominent and civil society is seen as a component of the health system in itself, and not just in HIV, but also with palliative care and so many others. And you see it even with the judiciary, where the magistrate courts are also equality courts, you know, for LGBTI hate speech and crimes. And so for me, when I think about, you know, what does that look like when they're at a HLM, you know, and Botswana is there with its own model with health posts, clinics, and hospitals, right? And then to some extent, you have community health organizations as well, depending on where it is. But I think, you know, what I think it allows now, particularly at a global level, is for people to start talking about health security and what that looks like in their own context, especially coming out of the pandemic, having seen so many where the number of beds, where the ICU units, the critical care, and the lack of infrastructure is quite telling. And even when, you know, just thinking about or linking the conversation with climate and migration, what that possibly then ends up looking like from a resilience standpoint. If, for instance, there's a conflict where we know, for example, like with West Africa, that has had, I think, 2-3 coups in the last 2 years, you know, and there's a possible additional conflicts from Ukraine. I think this is where the conversation around health system strengthening is obviously coming from. And so how do we bring that back to a higher middle income country like Botswana, that's a peaceful democracy, but still has so many inequalities? Because we know even when you're getting referral services, you still have to go to another facility. Your out-of-pocket costs in terms of taxi fare, you know, when you have to now buy certain medicines because the state dispensary does not have any medicines. And so these are just some of the things that, for me, I'm reminded of, in that communities have to be at the heart of it. Because if you look at one person who happens to be intersex, based in Matengwane, and is unemployed, and maybe is experiencing gender-based violence, and is HIV positive, and they now have to go and get cervical cancer screenings and make sure that they're able to get their refills, and then make sure that maybe their infant child can get appropriate vaccinations. So that means that they might have 2 or 3 different health touch points, because we know a health post will not be able to address the individual and their child. We know even a clinic might only be to some extent, because maybe the operating hours are up until 4 p.m. And that means she needs to finish earlier so that she can travel and then be able to access services or fall in line. So I think for me, when we're talking about health system strengthening, it means primary health care. And I'm glad that at least this is the conversation that's emerging in Botswana, and not necessarily a conversation, yes, a policy conversation in terms of strengthening. And we know that we just had a mental health act that has just been adopted. I'm not too sure to what extent that's inclusive of communities, but I think the fact that the policy and the legal infrastructure is an enabling environment, unlike other contexts, means that Botswana can be a benchmark. And I think that's an opportunity for us to sell, to convince our leaders for that political leadership, to convince even our narratives to say, let's just not focus on HIV as a syringe, but that there's so many other elements and social determinants that can be linked to it.
Brilliant. Thank you so much. Nana and Fitzo, I don't.
What Dumi said was quite comprehensive. Just to recognize that in the declaration, especially the one for PPPR, there's a specific acknowledgement of the distinction between community-led health services
and community-based services. Oftentimes we complain to say, but nobody's very clear about what that looks like. And so it means resources, programming is usually just limited. But the fact that it has been recognized that communities themselves can be the agents of their own change or support their health outcomes, that's really important, because it means in a pandemic situation, there's a level of resiliency that governments will be able to adopt to immediately say, okay, let's pivot, we need to do this. We need to use community members as early warning systems. We need to, we need to engage them to support, highlighting that there's an issue here and that we need to send resources here. So it makes you more efficient. I think people talked about efficiency, allocative efficiencies, but also programming efficiencies. How do you make sure that the health system is able to adapt and be malleable to whatever condition is there, right? I think COVID taught us many, many lessons. And it's one pandemic. Other colleagues have talked about mumps, resurgence of mumps, cholera, many other things. We need to be able to react using the health system in a very resilient way, which says no matter what it is that befalls us, we can still come out with the minimal amount of mortality from a situation. And that's what makes a health system resilient. And look, meaningful engagement of communities, not as an afterthought, but as a partner in the response is, for me, what is critical to a resilient health system. Thank you.
Thank you very much. All has been said. So, as Nana and also Dumi mentioned, I believe the political declarations have attempted to cover, especially when it comes to community participation and also community systems. Also, that would imply, and that also there is not imply, but there is also a mention on really building resilient and sustainable systems for health. My argument would still go back to the title of the HLMs or how they are captured. It is a political declaration again. That's what I really want to emphasize, because I believe really understanding that and also positioning ourselves from that really matters how we do the implementation at country level. To build resilient, sustainable systems for health, there is a lot that we need to do as a country, as a continent. But one of the clear indicators being our manufacturing capacity within the continent. That's why we're so much debating on the language. As Priyanka mentioned, there was a debate around, especially within the, I believe, on the PPPR declaration, whereby there was a push of language to kind of make it mandatory to share vaccination, IP rights and such. But it was very much also insisted upon that language was kept as voluntary sharing of IP rights, voluntary sharing of technologies and such. And within a political declaration, voluntary might mean yes. So these are the things that we need to be very careful in terms of its implementation, its interpretation as well, because at the end of the day, it's voluntary. And as long as I have the evidence that I'm struggling with my own capacity and technology, then I might not be obligated to share those things. So that is also something we need to be very much aware in terms of it's a political declaration. There is a lot of room for implementation. There is a lot of room for interpretation. There is also a lot of room left for implementation at national level. So here there is a component of financing, which is not really up to the standards that we were expecting. Just the 2 points that I've mentioned about in terms of testing, in terms of tracing and such, the financial commitments have not yet been dealt with in a manner that puts us in a very good path in terms of really securing a resilient and sustainable systems for health. So yes, there is a lot to think about, to strategize about, and also to renegotiate on a bilateral and multilateral level. Thank you.
Colleagues. If you, I'll give you some time to think about key recommendations. Remember, we said tomorrow we are going to be focusing on writing an advocacy position paper. what would you advise civil society in Botswana to absolutely include in that document? And while you are thinking about that, I want to bring in the Minister of Health. I think in the morning they said something really profound that I think we need to look into, that during COVID-19, we saw countries basically putting self-preservation before livelihoods. And I want to ask the ministry if in their assessment of the 3 documents, if at all, this area has been fully covered. Are we indeed going forward, we are going to put livelihoods before self-preservation? Ke kopa le nele Dr. Mfokeng Mike. Bonela le kae?
E ba re bua ka community mme re tla re tlogela. Right. Thank you very much for that that important question. It is very, very important that we lived through that. We lived through a time where countries did put themselves before to save lives of the other people. Actually, people sometimes say, why do you want me to put the fire on you in your country when I'm also burning in my own country? And whether that is the same, that is how we're supposed to be thinking about that. I could say, especially looking at the PPPR one, because it is the one that mostly addresses, even though it's also interlinked with UHC, but it mostly addresses issues around sharing of countermeasures, sharing of any other thing that you can do to have that you can have to try and counter the effects of pandemics on communities or health systems or whatever. The thing about it is in this particular document for the declaration, they skim over it. They just skim over it. They don't make very solid declarations that, you know, countries should ensure that it is just kind of, if you look at, maybe, let me not go there. If you look at some of them, it's more like a suggestion that, you know, you can share, you may decide to share. You look at it also the way the sharing is happening when you look at mechanisms that are being proposed. For instance, as Botswana, we did sign up for COVAX, and we know that COVAX came in and gave us vaccines late. We would give people first doses, and then they'll kill us because their second doses are not there because COVAX had said they're going to deliver. But still, in the very same declaration, they're still talking about exploring things like COVAX, not exploring things newer, not even talking about how we are going to improve on COVAX, but just that we are going to explore sharing mechanisms like that. Same thing, TRIPS. TRIPS is this WTO thing where it was supposed to have this mechanisms that you can use for when there is pandemics. It was still there during COVID. It didn't work, but we're still referring to it in the same paper. We're still referring to things like TRIPS. There is all of these things that we can look at in TRIPS. Really, are we not going to say how are we going to improve on TRIPS? And it comes out in the document because clearly it didn't work out, even COVAX and all of those things. So it needs to be more beefed up. The My thing with this is, especially the PPPR one, even when we are looking at it, because it's less legally binding, it's just political commitment. When you look at it and compare to maybe INB or even IHR, which is a law, right? So it's more important for us to ensure that whatever it is we are making our heads of state agree to in the political declaration, we make sure it comes out stronger and very well defined in the other two documents. And if we don't agree with it and we're still trying to think about it in the other two, we just simply say, let's not have it in here or have it in the way that it is. Thank you.
I did, and it's only because I have to leave soon because I have a 4 o'clock meeting. So I'm sorry about that. But I just wanted to add something in terms of the talk around accountability that I heard going on. I think it's important not to divorce transparency from accountability. I kept hearing you talk about accountability, accountability, and accountability. By nature, accountability is retrospective. You're accounting for actions or taking responsibility for them. Transparency is throughout. You're being seen. So let's just take a mundane example of it. If you're saying to your boss, 1 hour review at the end of the quarter, you're fitting what you did in the quarter, the 3 months into an hour. If you were copying your boss in emails throughout, it's more credible to believe that you are actually doing something meaningful with your time. That's just a mundane example. So if you're talking vaccines, if you're accounting for how many you gave retrospectively, it's harder to say, but where were the ones that you delivered, for example? So I think I would say we should focus, not divorce transparency from accountability, just in the way that we don't divorce monitoring from evaluation, because evaluation is at the end, whereas monitoring is throughout. It's the same concept, I think, from a governance perspective. And then I think even data-wise, it's important because I'll just give an example also that's divorced from this. The IEC will tell us, I know it was in the papers today about, how many constituencies they've sectioned. If they tell us how many people registered to vote, and then they tell us how many actually voted, you can do something with the data, disaggregated. If you're only told how many people voted, it's actually in isolation, it's meaningless in terms of comparative analysis or data. So I would recommend, as you asked, that we not divorce transparency from accountability. And what can we do going forward about that? So I'm actually sitting next to Bukongo because the UNDP is trying at the moment to talk with the DCEC and Bukongo, since there's an MOU, and then it's an umbrella for CSOs, to say in the same way there's a National Human Rights Committee that's co-chaired by the Ministry of Justice and civil society through Diswanelo, that there should be a transparency and accountability one. And what it is, and it's harder in that space, given the complexities of it, but that there needs to be a checks and balances, and that it's not isolated, and it's not individual pockets that are keeping, duty bearers accountable. Because why is it a human rights issue, as we were talking earlier, is because we're rights holders. So we should hold duty bearers accountable. It's actually our right, legitimate right, but we're not doing that. We're handing over power on election day. And then at the end, we say, be accountable. Why? They don't owe it to you. We handed over the power. So I think essentially, my recommendation, and I think you echoed some of that, Agasha, to say, we keep saying they should account, we keep saying, but that it's important that there's some sort of mechanism in place to continuously monitor, because I can tell you what I've done for you at the end, but it's not as credible if I was showing you throughout what I was doing for you. And so that's my 2 cents before I leave, if you don't mind. Thank you.
We mind, but you can still leave. Thank you so much for your comment. I don't know if there are any other questions from the floor. While you are still thinking about questions, allow me to acknowledge the presence of the UNAIDS Country Director, Re Alanka. You are most welcome, sir. Re kopa roving mic, please. Bakandaba has a comment. Oh, he has a mic. Okay.
Right. Thank you very much, Cindy. So in my comment, I'll basically be talking about how Botswana now is considered as an upper middle income country. So that means we are losing funding from the international space, right? So now it is up to the country Botswana to basically invest some of the funds on its people. So that is to say that in terms of TB funding and moving forward, why can't Botswana then prioritize some of the funds into the TB program, right? And then also into political. I think the title of this meeting is High Level Political Forum, right? So where is the political will in terms of advancing the eradication of tuberculosis in Botswana? And also in terms of accountability, do we consider it as appropriate to have a coordinator who came in and said that they have not done any programming around TB, yet we're saying that people are dying from TB, right? Thank you.
Okay, thank you so much, Bakang. Diana.
I wasn't going to comment. I just wanted to remind you of the time. Yes.
Almost winding up. I just want to make sure that we are not leaving any comment from the audience.
I have a comment. It's Mandla. I have a comment.
Please go ahead.
Can I go? Okay, thank you to the panelists. So I have a few comments. So please bear with me. I know we're out of time. So the first question that you posed to the panel was about equity. So from our part, in terms of contribution, is that we believe that if we build capacity of communities, train that, because equity is about fairness and balance. I know that some people don't start from the same place. So I believe that those who are I think to have our regarding the HLMs are equitable. And another one is around priority setting at the level of the national development plan. Right now, the NDP, the one that we have, to what extent has it included prioritize the 3 HLMs based on the fact that post-COVID, the people we have now, we have the issue around TB, we have the issue around universal health. So in terms of our national development plan, in terms of priority, have they actually prioritized some of those issues? And then one other challenge, I think, to achieving equity at a national or even at a global level is because of the data in terms of the M&E systems. Our M&E systems are always fragmented, so it's always hard to come up with the evidence to convince the duty bearers to invest in some of the asks that we always come up with. And they'll always say, where's the data? Where's the evidence? Why do you want us to put money on this? So I think strengthening M&E systems will go a long way in ensuring equity and other things that the other panelists spoke about. I would also like to talk through the issue about accountability. Accountability, I think, for us, for Botswana, I think a policy and law reform is very, very important to ensure autonomy of accountability institutions. For example, the HR Commission right now is co-chaired at the Ministry of Justice. So who reports directly to the president. So it's very hard for that commission to either hold those who violate human rights accountable, because they are still playing the player and also the ref. So for another example is, for example, you have the executive that is made up of parliamentarians who are legislators, but we have this notion that the two institutions are independent of each other. So those are some of the things that that we should be looking at. And I like the past speaker on Abuaka, transparency. For most often and not, transparency is about sharing information, you know, and we're always begging for information. Sometimes communities are failed because they knew about things at the last hour and they are not able to take action and are not able to help themselves lead healthy lifestyles. Another comment, it's on RSSH. I did put some comments on the chat. So one comment is just that in terms of community systems, is that we need to understand that pandemics start and end in communities. So hara center model wa HIV warna that adopted the 3 ones. And the 3 ones principle I think right, it's one coordinating agency, one strategic plan, and one M&E system. So I think as we go along, sustainable systems, but at the same time, we ignore the principles stating it's our right to health, which is affordability and accessibility. Dumi did speak to that earlier on. A country like Botswana, a higher middle income country, but you have people who still cannot go to a facility because they don't have taxi fare, because the medication that they have been prescribed is out of stock, and they are forced to go to a pharmacy and they are not able to buy that because they don't have the money. So issues, the intersectionality of socioeconomic status and health, climate change, so all those things are interrelated. So I think we need, going forward, when in our recommendations, we need to be addressing some of those underlying issues to ensure that we get what we really want out of this paper. Thank you.
Thank you so much, Manla, and I'm going to bring the conversation back to our panelists. Your parting shots. Remember, I did ask that you speak to key recommendations that should really form part of the civil society document. Anyone who wishes to start may do so.
I can start. Just a few, and I think we talked about them. Basically, that the declarations need to ensure equitable access to vaccines and treatments. It needs to be clear about needing to increase funding for health systems, improving data collection and surveillance, like Mandla talked about. We need to have the ability to be able to monitor the trends and track outbreaks and better prepare for these issues. We need to have concrete actions and targets so that it helps with continuous monitoring and accountability. And then we also need to look at things around improving mental health care, addressing non-communicable diseases, and increasing investment in research and development as well. I think it's something we always look at there, but it is really important to learn from it and also to support progression. We also need to pay particular and greater attention to social determinants of health that can influence access to care. It's bottom line, if we don't look at that, it's remiss of us in terms of the approach. So it has to be very clear about what's going to be done about that. And then the voices and experiences of marginalized communities have to be at the center of decision-making anywhere, across every structure. It's really, really important, because if we leave people out, the response will not be a comprehensive response. They will be back in 3 years' time to have the same conversation. Yeah, thank you. Oh, wait, financing. Did I talk about financing? Oh my God. Resourcing. We have to come up with innovative ways to resource. We have to think outside the box. We have to do business unusual to ensure that when we are looking at health, when we're looking at climate change, when we're looking at all these intersectional issues, we look at it as if there's one single pot of resourcing, and we make sure that across the board, we are resourcing efficiently, and we're resourcing with not just domestic funds, but all funding that's available out there to make sure that we are giving the best service to communities and making sure that we move the needle on these epidemics. Thank you.
Thank you. Nana has explicitly mentioned all. So just to kind of maybe talk about the approach, especially of the approach that we kind of just adopt in terms of producing the civil society statement. Mostly, my brother was also kind of mentioning that Botswana is now an upper middle income country. That's context. So we need also to apply this lens while crafting our civil society statement. Nana mentioned about financing. It has financial implication. Financial implication has health system implication. Health systems implication has community system implication. So the one indicator has a long way to go and to kind of affect the rest of it. So it will be very important to look at financing with the angle of Botswana now being an upper middle income country, and also to be very specific on that one. Very much also to look into climate change within the resilient, sustainable systems for health. Within equity, it's been very well articulated by Dumi. So it's not just making sure we count the enablers like finance and such, but also to be sure that there are those determinants that also go a long way in terms of equity, in terms of services, in terms of access. And more so to look into what Natasha was mentioning, to apply the transparency lens to accountability, which she very much put in a very good scenario that I believe would make us also very much think about. So it's more of really looking at the position statement that we'll be producing, address these key issues. Thank you.
Thank you, Makelemi. I think for me, it's also full circle because at our last state of UHC commitment consultations, we had keynote addresses from Mr. Malvia and Mr. Letlhare in Francistown. And so I think for me, just bringing back some of those conversations, what's key, beyond what has already been said, is really in the quality and the type of information that is shared, in that recognizing the stories and the experiences might not fit within certain reviews and assessments, and acknowledging that that still is also valid data in terms of community experiences, in terms of behavioral or health-seeking behavior, and also understanding social determinants. But I guess more important to some of the elements that were mentioned, and I think looking forward, is how do we ensure that there is a limited tax leakage in the form of illicit financial flows, in the form of transfer pricing, where we know full well that maybe we're not getting the best kind of mechanisms in place to ensure the resources needed can actually be mobilized in country. And I think for me, that also is directly linked to how we prioritize, because the assumption is that if our goal is to be a higher income country, that means we can take care of citizens. And so what does that then mean and look like in terms of allocations that can be a little bit more community centered? And I guess, for me, the biggest point that I think will address many of these issues is acknowledging, recognizing, and institutionalizing socioeconomic rights. And I think just looking at the history of Botswana before, when it was not able to ratify or domesticate some instruments because the infrastructure needed to be in place and because Botswana needed to prepare itself, and also knowing that, there can be strategic litigation, I think for me, it goes against the whole concept of progressive realization that's embedded in socioeconomic rights, that says that you can be a state, you can have limited resources and capacity, but you can progressively work your way towards fulfilling universal health coverage and ensuring a strong primary healthcare system. So I think for me, it's not about reinventing the wheel. It's really about recalibrating our own infrastructure and actually aligning our health, human rights priorities in the very same direction that we want to go. We went from a research agenda to a mindset change. Why can we not integrate human rights literacy to ensure that there's the kind of limited out-of-pocket costs, the kind of limited or compromise towards access to services, and also maybe more importantly, ensuring that communities can be at the center, even as carers and not just as users.
Thank you so much. Can we give them a thunderous round of applause? You will agree with me that we had the best panelists, we had the best brains the universe can offer. So thank you so much, colleagues, for your contributions. This marks the end of our panel discussion. I guess some of the conversation we can continue having over dinner and tomorrow and even for some time to come. So thank you so much. I hand over to Director of Proceedings, Mayor Diana Misrili.
Thank you very much, Cindy, and the panelists. I hope finally our communities were able to pick something. If not, tomorrow we must do better. Re Alanka, Dumelara, how are you? We acknowledge your presence. We are worried that we are not seeing UNH. Now we can smile. So colleagues, as we draw close to the end of today, I just want to allow Cindy and Keba, our rapporteur, to wrap up by reflecting back to us key messages that came from today. I don't know whether Cindy was also doing that as she was facilitating. So I'm going to allow our rapporteur to reflect back into in order to help us to build advocacy messages, which we will include in our and also probably refer to as we examine the 3 HLM documents, 0 draft documents. Without much ado, can I invite you? Are you ready? Okay.
Where is my signal?
IT, can we please
yeah. Please help so that we don't stay tired. Okay.
Good afternoon. It's been a long and very productive day. Are we tired? Dumela? Okay. We had a very long and productive day, I believe. We have amongst ourselves very deliberations, key deliberations since we began this morning. I just want to reiterate the key messages from the morning session and the afternoon session, particularly with regard to the key objectives. That's why I highlighted at the beginning of the meeting. The purpose of our two-day meeting is to review the zero draft documents that were mostly talked about by our panelists and also the speakers since this morning. For the 3 HLMs and Botswana's commitment to UN HLM targets, we were to also discuss country-level plans for joint mobilization and advocacy, of which we need to end up with a country position statement and engagement roadmap. We are also expecting to draft a high-level advocacy letter to call for Botswana's commitment of the political level participation at the coming HLM and inclusion of civil society and communities in country delegation to the HLMs. The other thing also is for us to establish a civil society engagement platform for advocacy towards the 3 HLMs that we have been deliberating on since the beginning of this morning. I'm wondering if we are all together or is the afternoon and fatigue? From the key deliberations that we have, I have sectioned the presentation in 2 sessions, from the morning and also in this afternoon's presentations with the panelists. I've identified opportunities, gaps, and recommendations. And I should say that at the end of the panel discussion, there were quite very strategic and key recommendations that they shared, some of which would also appear in some of the areas that I've highlighted. In terms of opportunities, from the presentations since this morning, we see that participating in the high-level meetings that are coming, is one of an opportunity where we'll be able to advance and also advocate for key issues of advancing the PPR and universal health coverage. And this also would mean the participation of community leadership society. This is where we'd be able to really speak up to say that involvement needs to be part of the delegation. And also the other opportunity is for us to have a coordinated one voice, both with regard to the national advocacy or bilateral dialogues that we need to look at the commitments and also to establish think tanks, both within Botswana, within our region and Africa as a continent with regard to the PPR and universal health coverage. We're also looking at data uptake and usage. It was mentioned that there is data, but do we use it? Do we learn from the information that we've already collected to inform our programming or to inform the policies or even our advocacy messages? So as we prepare our advocacy key messages to persuade our leadership, these are some of the things that we need to bring forth as civil society with regard to what we've been doing. And then the issue of transparency and accountability. Are we able to share with each other the information that we have collected to provide evidence programming and to provide informed decision-making when it comes to the data that we have collected? The other opportunity that rose was the use of existing platforms to ensure equitable resource utilization. Do we need to reinvent the wheel, or we need to look back at the TB and HIV model and see where the best lessons can be captured as we look towards the PPR? And then the other opportunity was communities as agents of healthcare system strengthening. Can we bank on our community structures to be able to facilitate and ensure that the little resources that are going to be invested are properly utilized, and we ensure that there's resilience within the structures that would be working within? Apart from the opportunities that I've highlighted here, there were also gaps. One of the gaps that was highlighted from the presenters was the absence of accountability structures. Where do we ensure accountability as civil society, and how do we ensure that we hold government accountable to the commitments? Civil society and community engagement are lacking. How do we ensure that this partnership or the collaboration is strategic and is able to address the key mandate? the voluntary provision of data, it gives leeway to say, would I be willing to give you my information, or I can refrain from sharing such kind of information. And this is brought about because of M&E systems that are fragmented. Within the civil society, you use your own softwares to capture the information, but how do we ensure they are coded to feed into the National Data Bank? At the same time, we currently do not have targets that are set for TB. And this is another key aspect in which we see a gap. So in terms of our programming, we are programming or we are designing interventions for TB, which are not informed with national statistics or global statistics. The absence of manufacturing and technology developments and know-hows. Because of what happened or the experience from COVID-19, we realized that as nations, as the continent, we need to have the think tanks that will be able to devise technology that we can use within our country and national context. Global Public Investment Week. Even here in Botswana, it was mentioned that in terms of financial public commitment to TB eradication, this is something that is still lagging behind. Somewhere along the way, we lost track of how we are eradicating or reducing HIV and AIDS infection and TB. So this is where we find ourselves now having to go back to the drawing board to redraft our plans. Equity needs to be specific to include other groups left behind, because when you look at the declarations or the commitments, they are not really specific. And when something is not specific, it gives a leeway to various interpretations of how you understand it or how you find it will fit within your framework. So there is need to ensure that it is clear and specifically articulate what this equity looks like and which groups are going to be involved and how are they going to be involved. The issue of intellectual property and patents exacerbated marginalization. I think during the COVID and also with the HIV pandemic, there were issues surrounding immunizations that were traditionally prepared. And also with other companies outside coming up with vaccines and the issue of the money power. Those with funds were able to buy vaccines, and those without funds or the purchasing power, they were the last resort. We learned that through the COVID experience where countries were able to access vaccines earlier, whilst the African continent, majority of them were the last resort. Voluntary sharing of resources, room for exploitation. It goes back to profit making, that as civil society, we also need to look into issues of how our entrepreneurs are able to exploit areas where there is an opportunity to make money. And in that particular case, it's medicines and vaccines, the pharmaceutical industry. I don't know if we have the private sector here also to partake in this dialogue, to also share that as civil society, we advance the rise of access to health. And ensuring access to health means even the profit-making bodies need to take consideration of those that are not able to afford high charged medicines. We are looking at ensuring representation of CSO and community structures in high-level meetings. This is one of the areas that we are gathered here today and tomorrow as we prepare the documents. The development of a global framework to help support tracking for pandemic to ensure there is no one that is left behind. This is to ensure that there are specific key recommendations and global frameworks that are clear and not left to interpretation. Mobilize government and CSO resources. There is need for us to lobby government to have a specific budget that will be able to advance the universal health coverage mandate. Health financing, how much are we looking into issues of health being one of the key areas where government invests and also other private entities. That is, there is need for us to lobby for public investment when it comes to the 3 HLMs that we have been talking about now and advancing the mandate. The other section was where we were talking of issues of climate change. I think this is another area where sometimes for Botswana, we seem to be lagging behind in terms of advancing current issues or global matters that affect us. Climate change, other countries are advanced, but us, we are just starting to track our carbon print. So these are the issues that we also need to incorporate when we look at health. With regard to what has been happening, the declaration of the drought. So it is telling you, it is showing that climate change is upon us. And as we talk of health systems, health investment and financing, climate change needs to be incorporated as part of the key issues, as it also affects accessibility to health, resource allocation and prioritization. The other opportunity here is harmonizing trade agreements, policies to ensure flexibility across borders within Africa. Here we are also learning again from what has happened during COVID-19, where we had our borders closed. And yes, it comes as an opportunity now where we see investments internally within the nation. But at the same time, how do we ensure that it does not affect our accessibility to health services? And how do we ensure that it does not affect the livelihood of someone who is at the grassroots level? Utilization of knowledge and experience across different sectors. Are we able to ensure that we share knowledge within the different sectors that are affected by climate change or that ensure accessibility to health? Here, we are also looking at engaging meaningfully with partners. This could be partners that are going to be funding, partners in the technology industry, partners in the development of vaccines. Advocacy efforts towards mitigation of climate change. How do we ensure that we lobby for the inclusiveness of issues relating to climate change as we are targeting the universal health coverage and also the implementation of the PPP? The other issue about, I will not talk about the gaps, but a few of the recommendations that I've mentioned there. What came out of the speakers also in the presentation was the silo approach, that we need to stop working in silos and work with each other. And by doing so, we'll be able to strengthen our information management systems, because we would end up having mechanisms that would monitor the implementation of the declarations. And the other key recommendations that I picked were from the panelists, of which they were talking about funding, that there's need for us to have enough resources, actually increase in the budget allocation for funding for health systems, and to provide concrete actions and targets that are going to ensure there is proper implementation. The other key recommendations that they mentioned was for us to ensure that voices of marginalized members of society are also, as we look at these documents. They also mentioned innovative ways of financing. Let's not only look up to government, but come up with ways in which we can be able to bring in financial resources. They talked also about the issue of Botswana being an upper middle income. How does this affect the way in which we would be able to execute universal health coverage, and also the declaration, including the having to advance or to lobby for political commitment in the execution of our PPPR, because already we are fighting over a small bower of resources. And then the other issue that they mentioned was quality and type of information that we share. We need to ensure that the type of information that we share needs to highlight experiences that we have within our communities and within the systems, and to also ensure that as we share these, they are aligned to promoting human rights and health access. So in doing all this, what was key was to ensure that communities are at the center. In summary, is to implore that we are going to invest in the prevention and control through sustainable and adequate resources, to accelerate the implementation of quality prevention of universal health coverage and the triple PR, and to also ensure alignment of development and declarations to achieve UHC, and engaging communities, civil society organizations, and other key actors in decision-making processes, aiming to keep UHC people-centered and equitable. Thank you very much. That is the summary of the afternoon. I'll give Cindy, in case you have any additional comments.
Thank you so much for the summary. I don't have much comments. I think most of the issues have been covered. All I can say is that let's ensure that TB, we keep TB included. As it is, you think it's UHC and PPR only. And that's how historically TB has been left out. And that's why the TB coordinator was saying there is no budget coming from government for TB, but rather we depend on Global Fund. As a transition country, that is worrying. So let's remember to keep TB at the center as well. I'll move on to the next session. Basically, this summary is to guide people who are coming in tomorrow to develop the advocacy document. So I won't open it up as much for comments. I think as they write, they will also reflect on what was said and what to add and what to remove. So I'll move on to the next session, which is about selection of a committee